but okay. Hello, every participant here. It's really appreciate to attend here this session, but it takes a little more time to arrange all devices. Yeah, so please wait for for a few minutes. Yeah, thank you.
Hello.
Good afternoon, everyone. Finally, welcome to Halby once again. And thank you so much for your patience. So we are starting now. Distinguished dignitaries, esteemed guests, national and international speakers, participants joining virtually, and my dear colleagues. Good afternoon and namaste. Myself, Kusum Sahi, and it is my privilege to warmly welcome you all to this parallel session, an integral part of the 24th FERCAP conference. This session is centered on the theme Educating Research Stakeholders, aiming to advance dialogue and deepen our collective knowledge in research ethics and governance. Today, We are honored to have with us Dr. M. Shin, a respected leader in medical statistics and chair of the Korea CDISC Coordinating Committee, and Professor Prakash Chandra Bhattrai, a committed advocate for health research. I would like to request our chairs to come on the stage if you feel comfortable. And please, a round of an applause to our chairs.
Okay.
No. So you can say, I can give you an introduction.
What is this one?
Yeah. You can say, I can give an introduction. You can just here. Yeah.
Why? You want to introduce me? Already introduced me.
Yeah. Okay, now a short introduction for our first chair, who is our Miss Dr. M. Hessin. She served as a professor and the chair of the Department of Medical Statistics at the School of Medicine, Daegu Catholic University in South Korea, a position she has held since 1997, if I'm correct, and I have been actively involved with the Korea CDISC Coordinating Committee, where she served as a chair, focusing on implementing global data standards in clinical research. Her contribution not only limits to that, but extends to being a member of various boards, including the Multi-Regional Clinical Trial Center at Harvard and the Korea Data and Information Society. Likewise, now let me introduce to our second chair, Professor Prakash Chandra Bhattrai, serving as a professor and Associate Dean for Research Management and Development at Kathmandu University. He had been awarded not once, but twice with a very prestigious award, that is 2015 Paul Begley Award for his doctoral thesis on ethical leadership and the highly commended award for the Outstanding Doctoral Research Award. Professor Bhattrai specializes in research methodology and has been actively collaborating with national and international organizations as a faculty member, project evaluator, and trainer. He also serves as Secretary of the Comparative Education Society of Nepal and is deeply engaged in promoting integrity, ethical leadership, and societal reform. Now, proceeding with enthusiasm, I now hand over the session to our esteemed chairs, Dr. Maria M. Hessin and Professor Prakash Chandra Bhattrai, to lead us through the enlightenment discussion. Thank you. Thank you.
Okay, thank you so much. And it's really sorry that it takes time is a little over. So this session is educating and the research stakeholders. So there are 5 speakers here. So we'd like to give 10 minutes to every speakers because 15 minutes I think it is not enough to finish within the within a time. So I'd like to invite the first speaker. The first speaker is Dr. Nishakanti Kopalan. He is from the University Malaya and the Johns Hopkins University. Her presentation title is the Context-Specific Casebook for Southeast Asian Bioethic Education. Yes, let's please give a quick applause to her. Yeah.
Hi. Okay. So I guess everyone is very eager and already a little bit anxiety kicking in with the delay. So my name is Nisha. I'm actually here to talk about a context-specific casebook for Southeast Asian bioethics education. My co-presenter could not be here, Dr. Joseph Ali from Johns Hopkins University. Right. So I'm from the University of Malaya, Medical Humanities and Ethics Unit. I'm a senior lecturer there. I teach in the Masters of Health Research Ethics program, which Dr. Sugarman so gracefully spoke about this morning. This is the outline of my research. And I'm going to just ask a quick question from all of you, audience here. How many of you are involved in teaching ethics or in some sort of training of ethics committee members? Show of hands. Okay, amazing. I can see like a 3/4 of you are actually involved, which is probably one of the reasons why you're interested today. So one of the reasons why we actually embarked on this journey is pretty much the same. As you know, bioethics teaching requires appropriate tools and resources, and one of the things that we commonly use is case studies. And I think pretty much all of you would agree with me, that's the one way that you can show case-based issues or real-world issues and talk about how do you mitigate those problems or what can you learn from those problems so that you can improve them and make or prevent that problem from happening. So our hope is to ensure that case studies engage learners with real-world ethical issues and dilemmas. And not only that, it has to help foster critical thinking, but it's not just critical thinking from a general perspective, but also from a very tuned issues that are local, that are more context-specific, that are more cultural specifics, and so on and so forth. So therefore, you make ethical decisions. Over the years, we have had the privilege of many case books, and I think you have all seen most of this. The first one is the WHO case book, which even our program, the Masters of Health Research Ethics, MORI, uses very rigorously. We also have the ethical issues in international biomedical research that was done by one of the, I'm not sure who they did it, but the second one is Human Dignity and Human Rights, that's from UNESCO. And our co-presenter, Joseph Ali, he's also part of the last one, Research Ethics in Epidemic and Pandemic case book. He's also one of the co-editors in that book. So we use all these different cases from these different case books to teach ethics and bioethics to our students. But one of the things that we realize is that the WHO case book, although it's health research ethics specific, but a lot of the cases are not just from Southeast Asia, they are internationally. It's written by people from the global north, people from the global south, and some of the issues are a little bit outdated now that we are moving forward and evolving in terms of research ethics issues. So, why am I showing this? Is because we are teaching it in the program. So the Masters of Health Research Ethics program, as Professor Jeremy Sugarman would have spoken in the morning, is offered at the Faculty of Medicine, University of Malaya. And it was developed as a part of a collaboration with the Johns Hopkins University with the NIH US Fogati International Research Fund. It's one of a kind in Malaysia, it's one of the very few in the Southeast Asian region, and we realize our issues are very specific. We have students coming from Philippines, from Vietnam, from Indonesia, from Philippines mostly, and the issues that we are discussing is not normally found in those ethics books that you saw earlier. So we thought that it's one of the issues that we needed to deal with, and so we embarked on this journey. It's been a challenging journey nonetheless. We put out a call for cases in the hopes of seeking specific cases that we'd be interested with for the region. We collected about 90 over cases that was from Thailand, Philippines, Malaysia, Indonesia, and so on. And then we went through a preliminary editorial review, and it involved a lot of people, especially, the editorial review was mostly me and Joe, but then we embarked on a more extensive editorial process involving Prof. Sugarman and a few number of our ethics expert that we have in the program, which is Prof. Adiba, Julia, Rumana, and so on. We also have someone from the Johns Hopkins giving us very specific formatting reviews. From there, we we went on to revision requests. The revision request was very extensive. As you can see, organizing conference can be difficult. Imagine 90 cases, each of them written by 4 to 5 authors, and now you need to get them all to revise the cases, get them formatted, and then proof, agreement proofs to sign, and so on and so forth. It has been completely exhausting and extensive process over the years. And we're happy to say that now in November, we are actually at a beta testing phase, which is a soft launch in a case to show you. This is how it looks like. So our casebook is called Cases in Bioethics. So it is published under the Johns Hopkins University Press or Project Muse. And it's an online repository system. Unlike the other casebooks that you have seen over the years, is a hard book collection that you need to buy from places. This is an online repository. You can access the system. You can get collection of cases. It is region specific, but it can be more focused in terms of different issues and themes that you're looking for by just searching the keywords. We have genetic research, biobanking, issues involving clinical trials, and emerging field. And the beauty of this is both the program, our program, as well as the Cases in Bioethics, both are funded by the NIH grant, and we are very grateful for that process. So that seems to be like the highlight of the moment, but the beauty of the whole process is the fact that it has a regional focus. And I think we are very proud to say that having cases from 83 finally tuned cases, all of them are from Southeast Asian region. And they are all very culturally attuned. Social impacts are very attuned to the region as well as the economic landscape of the low middle income countries within this region. And to make it more perfect is that although the authors are all from the region, making the real cases authentic, the reviewers are also from the region. So we are also ensuring the fact that while we have two amazing experts from Johns Hopkins reviewing the bioethical context of things, the theoretical aspects of it, but the scenarios and the issues involved are very much within the region. So the key features of the Cases in Bioethics is very comprehensive. Like I said, it has many different topics that we cover, but they are all practical impacts. These are not hypothetical cases, bear in mind that. These are cases that has been written by authors and researchers who have gone through those issues themselves, and clinical researchers who have gone through themselves. So which gives the whole idea of ethical dilemmas that much more impact, and regional concerns and the cultural nuances that they went through is real issues that you would probably face if you are within the region as well. And the additional thing is that the whole casebook is to train people, to educate people in the ethics and the bioethics and the research ethics. Our casebook has a whole list of the cases, and each of the cases will be elaborated in a nice scenario manner, but it also accompanies with a list of questions. And these are some of the questions that I'm listing here to show you that maybe some of these questions resonate with you, and questions that you have probably asked yourself over the years. What are the unique ethics and regulatory considerations should researchers consider, given that they will be doing genetic testing within the samples? We have genetic samples collected from indigenous population, and we have consent that is blanket consent that people that in that region or in that community are not familiar with. How do you deal with those things? So which is one of the reasons why we thought it was necessary to bring those kind of issues that you don't rarely speak or don't rarely find in the other casebook in here. The other aspect of the case is that it's freely accessible. It's free for everyone. So everyone can access it. No one needs to pay in advance to access it. You can access it since November this month. And it also ensures wide dissemination and utilization. We're not talking about people within the Southeast Asian region using this. We're talking about people in the global north countries who are teaching Southeast Asia issues to be familiar with it so that they also can provide well-informed information. And it's designed mostly for educators, researchers, and policymakers across Southeast Asia and beyond. And this is how the platform would look like. I can also show you a little bit more in a minute. And the bottom here, you will see a search button, so you can actually search. If you say autonomy, you'll see all the cases on autonomy get listed. So which is something that no other case book will do, mind you, because if you take a book and flip, you need to find those based on the, you know, the very back, there's a whole list of keywords. I did not do that. So in the case book, on the online one, it's very easy to assess. So that was one of the things that we were going with, accessibility. And of course, one of the key objectives here is to strengthen the bioethics education and research ethics capacity in the Southeast Asia. We are all within this conference today, are all from the same region in that sense. So I'm sure you will relate to me when I say, you know, we need to expand the capacity in that knowledge, and so we have real attuned, tailored, specific case book that is related to us. And while it helps to understand bioethics theory and actual research practice in the global health, the theoretical aspects may or may not, fit with the kind of research that we are doing. So it helps to enhance our understanding in global principles and how it applies within the local context. That's always been an issue everywhere. And as we are moving forward with AI research and global health research and climate change and health, you realize that you need a little bit more tuned kind of approach, regardless of what principles that you are adhering to. The dynamic learning tools, hence paired with the teaching aid, will give you the best tailored learning anyone can hope for. Of course, nonetheless, these are our amazing team, and I think we, all of us have been really interested in getting this out as fast as we could, but it could have gone faster, but it didn't, but it's never too late than it is now. I'm gonna go to the next slide, my last slide. So if you're interested, you can take your phone, you can scan the QR code, you can actually see the interface. Since I said this is still in a beta phase, and this is a soft launch, we are happy, and a lot of changes are being made as we are talking. The Project Muse people the Johns Hopkins Press have been really kind and giving us a lot of help in ensuring this gets better and better over the time. And so please explore and of course use it in your teaching in the future. But in the meantime, if you see anything that you would like to improve in terms of the casebook, please don't hesitate to email us your comments to mori@um.edu.my. And if you're also interested to learn more about the MORE program, the Masters of Health Research Ethics, it's a one-year program. There's scholarship available for Southeast Asian candidates. Please come and look for me. I'm very happy to talk about it. With that, I thank you very much.
Okay, Dr. Nishakanti, thank you for your presentation. For the Q&A, we'd like to have a Q&A session after all speakers' presentation. Yes. Okay, next.
It was a wonderful session. So now, may I invite Professor Narapon Prainwuyat. I think my pronunciation is correct. She is distinguished neurologist affiliated with Division of Neurology, Department of Medicine, Siraj Hospital, Thailand. And she has extensive professional experience, including visiting science at the Department of Neurology. Okay. That is in Mayo Clinic, USA. Okay. So it's your time, Professor.
Thank you very much. I would like to thank the organizing committee for choosing our presentation today. Got my slides? Not yet. Which way? No. Okay. Okay. This is actually the work of the first three names are my HRPU staff members, and the four are the IRB members. I'm the chairperson of this Siraj Hospital. Okay, that's me. forgot, they have to go backward. So this is our administration. We have 4 different IRB panels and 3 subcommittees, and our HRPU staff members in the office would have to work for us. And the roles of the responsibilities of our HRPU officers is to support us in protecting the rights and welfare of research participants by providing assistance to the members. IRB members in competent reviews of study protocols, evaluation of progress reports, update reports, evaluation of adverse event reports, and they have to be well equipped with knowledge and understanding in ethics of human research. And yet they have to do continuous improvement regarding this through appropriate training. And with the educational methods, the effective methods in learning is through knowledge sharing. Problem-based learning through examples and case scenarios and case books like you have heard before. We have to do group discussions, sharing views and experiences that each person has perceived, learning from one another as a teamwork, and then freely communicating in a relaxed environment. And that's the idea of group discussion. And then after that discussion, we'll be reflecting knowledge obtained. Then after the session, we need to have work instructions generated and from the conclusion we made during the meeting. Otherwise, it will be no implementation after that. So this is our presentation here, conducting educational activities among research stakeholders, and we are doing it with the HRPU staff. So the rationale is to increase the competency and understanding of our staff in providing effective responses to inquiries on initial reviews and post-approval reports from our investigators. They always ask our staff questions, lots of questions. And then after that, we would like to plan for a course syllabus in adjusting the educational sessions, using the information that we got from the common inquiries. Doing this as a proactive strategy in trying to tell our researchers that this is something not to do, this is something better to do with like this, something like this. And the steps of doing research is that I start with collecting and categorizing the consultation and inquiries received from our investigators. That will take like 3 months. Then after that, we design a set of questions on the common problems that in the initial protocol submission and the continuing reviews. For example, the adverse event reports, protocol deviation, protocol amendments, annual reports, so and so. And then after the accumulation of that, we validate the questionnaires through 3 experienced SRME members for the item objective congruence. Okay, this is the timeline. We submit to the IRB for approval 2 years ago, and then we got approval. Data collection. For the information that we collected during the 3 years period, there are 594 questions within the 60 working days. It's about 10 questions a day. Majority of the questions are provided by telephone calls. Only 4 minutes for each contact. You might think that it's something very short, but if you're doing something and you have to be interrupted and go to answer telephone calls, maybe you get bad mood after answering that question, so you have to come back and get yourself calm down again, continuing the work. So this is the interruption to our staff members. So we'd like to help them not to get interrupted by helping the researchers, investigators to know something that they can find out without asking our staff members. The questions are regarding the review type, both of the initial and review, continuing review equally. Affiliation of the inquirers. A third would be affiliated with the sponsors, industrial sponsors, and then other investigations from different clinical and preclinical departments, education, research, operational units. And the inquirers are mostly our research coordinators, about 2/3 of them. And the experience of those inquirers is less than 3 years in about 70% of cases. What did I ask about the initial review process? Before initial submission, we'll be asking what information is required, what documents they have to submit, and then we'll be asking for result and recommendation, asking when tracking the protocol number, meeting date, and the issuing the protocol, the COA. So these are the information that we got from that 3 months period. Regarding the continuing review, majority of the inquirers are from protocol amendments. Other things would be report of SAE at the site, documents required for protocol amendment, tracking for COA renewal, requirement for closeout reports, what to write down, when to submit, requirement for protocol deviation report, what they have to describe and track for the closeout report, acknowledgement, submitting investigator brochure and package inserts. These are the things that they have telephone calls to our staff. Okay, it's the next step. Questionnaires generated, and we designed for 2 workshops. The recruitment process is done in June. Since we have 12 IRB staff, 3 are already investigators, and 2 are general source. They are not working with the protocols. So there are 7 potential participants, which we request them to participate. All of them, almost all but one of them, had more than 10 years experience in working with IRB, and 1 participant just participated in 1 workshop only. So the calculation is from just 6 participants. There were 2 workshops, one in June and the other one in July. For the result of our study, we generate 20-item questionnaires and validate it for the IOC. Then we have interactive sessions. The workshop 1 consists of lectures, interactive lectures. That's the schedule for the first one on the 14th of June. We have pre-test questionnaires using our 20 items that we generate. Then a coffee break, and then we have interactive educational session explaining to the staff about several SOP-related topics. Then on the second workshop, they have 5 different cases. The case 1 is a types of protocol requiring SIRB review and approval, because this is the questions that lots of our investigators would ask, whether they have to submit for exemption review or expedited review. And then discussion about paper-based and online consent. And case 3 would be consent from parents for research in children, research on blood donors samples, because you have a very big blood bank, and many of our researchers would ask for leftover samples of the blood donors from the blood bank. But since they are taking the white cell from that samples, so these are the genetic materials. So the blood bank, actually they used to donate, give that, prepare everything, but right now they are kind of concerned that giving out blood samples with the DNA, genetic materials to researchers might have not so ethical. So we are asking for what to do. The 5th one would be recruiting more participants in a retrospective study, because lots of our researchers doing retrospective, and they have gathering too many, more than what they have asked for. So this is a very common issue in our institute and misunderstanding. And this is how we do it. Just relax in a meeting room with coffee and snacks. I remember that the snacks are very good. I can't remember exactly what the topics are, but the snacks are real great. So it's kind of relaxed, and all the participants are encouraged to give their experience. And so after that, we did the second session of the post-test questionnaire again, and we found that some of the items is incorrectly answered by more than 4 participants. So the number of that would be 15 or something like that. Okay, so these are the information. Even after the workshop, there still are misunderstanding or incorrect understanding our staff members. So what we conclude from our finding is that we want to assess the pattern of consultation of investigators received by our office. Majority were from telephone calls and from new investigators. The common problems will be used as a base to generate and validate questions and case scenarios for discussion for effective learning experiences, and then we identified area of improvement in the staff members. So is that enough for the investigation, something like that, research like that? Of course not. It has to be implemented. The common problems that I mentioned, that we gathered, will have to be mentioned in the educational courses, because we have to provide educational courses for our research about 4 or 5 times a year with different groups. So these problems that they have been asking would be mentioned to them in advance, so that if they are not sleeping during their learning, they will be able to remember. And then we will try to make the FAQ handbook for the researchers in case that they don't have time to call us. And then the HRPU staff, we have to make a work instruction so that include all of the problems that they have misunderstood. So actually the research educational in the stakeholders, as I mentioned to you, that we have the stakeholders will be researchers, assignment members, participants, and the staff. So we provide regular training for the basic courses, refresher courses, for the researchers every year. For the members, they have to acquire certificates, and we also provide SOP training yearly. And for the staff, they also have to get certificates for the training. What we would have done extra, last year we present in the FERCAP in Malaysia regarding our discordance rate among reviewers in an NIB. That's seen why our members are giving different opinions in the protocol. So we went back and then asked them to attend the full board meeting at least twice a year. And I'm planning to try to make them with different experience of the members. We try to make it coming close to one another. And this year we're presenting the work on the staff members, and they have to generate staff manual, work instructions, FAQ, and lecture topics. We're also doing a research on common errors with the protocol submission with our researchers are doing, and hopefully that will be done next year and present to you again. For the research participants, actually we have a chance to go and visit something like a research in a community, and they observe how they do the recruitment processes. This is one of the very good way to educate your participants to know their rights themselves. They can protect themselves instead of having the researchers protect for them. The participants themselves have to know their rights and what to do. Okay, thank you for your attention.
Thank you, Professor Narapon. Yeah, I'd like to invite the next speaker, Ms. Hui Chen Lee from Kasei General Hospital, Taiwan. Yeah. She will present using team-based learning in clinical research education. Yeah, she is a IRB, vice chairman of IRB and deputy director of nursing department. Yeah, thank you.
Okay. Ladies and gentlemen, good afternoon. It's a great honor to stand here today and share my study topic. My research is using team-based learning in clinical research education. Okay. I come from Taiwan, Taipei, Kasei General Hospital, CGH IRB, and nursing department. This is my CV. Kasei General Hospital Medical Network is for Taiwan. Have a medical center and clinical medical center, 2 regional hospital and clinical. Team-based learning, it is a structural flipping classroom teaching method designed to enhance education by promoting active learning, cooperation, and critical thinking for problem solving. Good clinical training is one of the most important topics and global trend in clinical trial quality and require appropriation teaching method. Education sessions are used extensively by clinical research team to provide ongoing clinical trial education and facility implementation of evaluation for translation of new knowledge to change practice with the research system. Good clinical training use workshop mean the integrated professional knowledge with the best available empirical evidence for decision making. Workshop emphasize the combine of research and documentation with clinical practice. This study purpose was to explore the effectivity of a good clinical practice workshop education approach for clinical trial team. To achieve the intended goal of the good clinical practice training standard, Taiwan Food and Drug Administration, TFDA, grant a project strengthening the training and qualification of clinical research professionals. This is this study number. Data or collection visa questionnaire, comparing knowledge through post-test, and assess satisfaction at the end of the team-based learning workshop. The study was conducted through 4 workshops held in Northern, Central, Southern, and Eastern region of Taiwan with a total of 310 participants. There are more female participants, 1.1%. The participant rate from the North is 31.6%, and 41.3%, and over 45 years old. The statistics, the result of the team-based learning workshop show no significant difference in statistics between gender. This gender is female is high, over 45 years old is highest. On service unit is in hospital is highest. Rest of the gender difference in statistics after team-based learning workshop have 9 questions. One question, after the workshop, I have a better understanding of the IRB between processes. Question 2, after the workshop, I have a better understanding of the significance of the risk assessment. Question 3, it will be more helpful to write a research plan after the workshop. Question 4, after the workshop, I have a better understanding of the tracking frequency by the IRB. Question 5, after the workshop, do you think the IRB plan a role of assessing and protecting the PI? Question 6, this is a related question. After the workshop, do you think the IRB plan a role in hindering research? Question 7, after the workshop, do you think the IRB review case process is transparent? Question 8, after the workshop, do you think it is time consuming to submit the research proposal for review? Question 9, will you attend a workshop course next time? The proportion of male and female agree to the item is the highest. Expect question 6 is negative question. Question 6 is disagree is highest. There is no significant difference between male and female gender. Team-based learning workshop can increase professional knowledge and skill. It is recommended to implement for advanced training course. Team-based learning education provided by experts can bring about effective knowledge transmission from face-to-face teaching strength. It concludes that you do the skill of the professor who organize the workshop and their level of expert and experience. They were able to induce more education effect on the learner. In this research limit, small sample size and lack of generalized of result. In this study, team-based learning workshop skills were assessed immediately. After the workshop, then long-term outcome did not exist. The research design only collect post-test result and need to collect pre-test baseline for compare in the future study. Future suggestion. In this study, team-based learning was used in the workshop, and the success of the workshop might have been due to the use of team-based learning training strength. Results from participants who experience team-based learning session indicated that team-based learning improve teamwork, self-study, problem solving, communication skill, and professional. It is a recommendation that the effective of team-based learning workshop will be explored in future study. This team-based training photo picture. Okay, thank you for your attention.
Thank you, Ms. Lee. Thank you for the presentation. It's the wonderful presentation about team-based learning. At this moment, I'm inviting Micah Angela A. Kadok. She's from Department of Health, Philippines. And she serves as the Health Program Officer as the Health Research Division of Health, Philippines. So, yeah. Micah. She's not here? Virtual? Yeah. With some technical difficulty, we are inviting the next presenter now. She's Sui Wen Su. She's from Cathay General Hospital, Thailand. So, Executive Secretary at Cathay General Hospital, Taipei, Taiwan. And she did her PhD in medicines from Chun San Medical University. And she has very intensive experience of research ethics. So let's join hands together to welcome her. Thank you.
Yes, okay. Okay, it's okay. Thank you, introduce. I'm Xu Cui-Wan, come from Taiwan. This is my background. Today, this is my background. Next, please. Today I want to talk about an issue topic, clinical trial for the research team. Clinical trial for research team, clinical trial are crucial for advanced medical science, but their success depends on skill and well-trained team. Effective training empower their team to conduct the trial safety and ethically, ultimately enhance the quality of research outcome. Background, world training as clinical research can facilitate the clinical trial, will enhance their research knowledge and ability to conduct trial. Adequate training is consistent with key clinical and regulatory objectives, provide high-quality clinical trial, ensure the staff have the skill, competence, and capability requirement and appropriate qualification. In 2024 revised version of the Declaration of Helsinki, article tells that medical research involving human subjects must be conducted only by individuals with the appropriate ethic and scientific education, training, and qualification. Research on patient or health volunteer require the supervision of the competence and appropriate qualified physician or other health care profession. To achieve the goal of the GCP training standard, the FDA had provided supplemental funding to support the project, strengthening the training and the qualification of clinical research professional. This is number. The goal: improve the scientific quality and the ethical knowledge of clinical trial through the enhanced training for all investigators. The training program was designed. The training program was designed with two primary components. The first is training of clinical research professor in clinical trial on the basis of the GCP. The second aim is training on the advanced knowledge and the latest clinical trial trend. Training includes representatives from the pharmaceutical industry, clinical trialists, and the TFDA, as well as participate clinical research professor association, cooperative institutional training program, and the IRB member. The multidisciplinary approach promotes a comprehensive understanding of clinical trial and encourage across-department cooperation. Survey question design use the pre-designed self-administered questionnaire. Cause-effect evaluation use the lecture test question as positive score for pre and post test. The study conducted four basic education training section and one advanced training course. Result: a total of 464 participants of the course, and the final number of the participants was 435. The attendance rate was 70.1%, and the total 13 people participants were included the analysis. Among the education participants, we can see the demography. Female, 63.8% was female. The age were over 55 was 52.3%. The majority of our participants come from the hospital. And 43.3% had submitted research protocol for review in the past 5 years. This is demographics. The second two tables, we can show the analysis of gender difference in the learning effect. Pretest score, the mean score of the pretest indicate and initiate the performance comparison between male and the female participant. The post-test mean, the post-mean data show both groups improve after the training education. Different in learning game, the data shows statistically significant improvement in learning outcome across the gender with a p-value of less than 0.001, indicate the gender difference in the learning effect are significant. We can ask a questionnaire, open questionnaire. Questionnaire 1, because you are interested in taking, out of all participants, 63% express a preference for online course. This indicates a significant interest in online learning, highlights the need for flexibility and accessibility in course format. Open question 2. Did you gain anything from this seminar? 39% of participants report they're now better understanding what need to pay attention to when conduct research. The response reflects a key benefit of the seminar as it enhances participant awareness of critical area in research practice. 3 questions. Because you are interested in participating in the future, participants show specific interest in the future course topic, with 27 express a preference for course on clinical trial designs, and 26% indicate interest in IRB submit and regulation. Conclusion: future course design will focus on four key areas: authority, project sponsor, industry, and the IRB. By integrating the responsibility and the obligation of the all parties, we adapt our current to the changing research environmental and improve the effective and the ethical standard of clinical trial. This is we go to the Taiwan now South, Central, North, and the East. This is the participant. And this is the photo. The same Li Huizhen. Thank you for attention. Thank you.
Thank you, Wu Sui Wen. So now the final presentation. Micah Angela. Is fine? Yes. Please proceed.
Of the Secretariat for its Public Health Ethics Committee. So to start, here are some of the related laws and issuances on public health ethics in our country. Starting off with the Universal Healthcare Act of 2019, which has a specific section, Section 35, which specifically states that the implementation of universal health care shall be strengthened by the commitment of all stakeholders to abide by ethical principles and public health practice. To operationalize the other specific provisions of this section, a series of administrative orders were also crafted. First, in 2020, which is on the creation of Public Health Ethics Committee, or PHEC, and its function of public health ethics review in the department. In 2021, Two more orders were created. First, on the conflict of interest declaration and management of all officials and consultants of the department, and next is spearheaded by the Food and Drug Administration, which is the financial disclosure report of medical and pharmaceutical companies. The training itself was conducted face-to-face with the following sections: lectures, case studies, and open forum. And the orientation had the following objectives. The first is to discuss the basic principles of public health ethics and ethical leadership, and to contextualize it in the universal healthcare law. Second is to orient the actors and stakeholders in the operationalization of public health ethics, to identify the ethical issues, dilemmas that they may face in their current activities. Next is to capacitate the stakeholders in their respective roles in managing the ethical issues, dilemmas, and challenges that they may face. As for the participants, we invited all directors, program managers, and officials in the supervisory level, so even medical center chiefs from the central offices, regional offices, and hospitals and drug abuse treatment centers. So basically all levels of our department were invited for this. So in total, we had 7 batches with all in all 305 participants. The batches of training started at October of 2023 and ended at August of 2024. During the start of our training, we had a needs assessment. So these are some of the answers of their participants. The first one is, how do we even enforce conflict of interest management in our offices or units without it interfering with the actual work of the officials? Second is, what is even the difference between personal ethics, professional ethics, and public health ethics? Next is how these policies that we have in terms of public health ethics affect the existing practices that we have right now. And last is, how do you even apply these ethical principles within their respective functions? As for the lectures, these were identified by our committee members, starting off our orientation training with the overview of public health and defining what an ethical leader looks like in public health. Next is the discussion on relevant laws and guidelines related to public health ethics and how to manage conflict of interest and why is it important in public health. Next is on the ethical decision making in public health, and lastly, how important evidence-based policymaking is in public health ethics. For the case studies, we identified 2 sets of cases. The first one are for the central offices, which handles national level policies. So these cases were lifted from the publication Public Health Ethics, Cases Spanning the Globe. So the first case is on the public-private partnerships, role of corporate sponsorship in public health. Second is whether mandatory vaccinations in outbreaks are even justified. Third is the ethical consideration of drug trials in developing countries such as the Philippines. And last is the non-adherence to treatment in patients with tuberculosis and how this affects a greater population. For the case studies for regional offices, hospitals, and treatment centers, these are more local, meaning these were actually reported on in the news and only anonymized, or some details were changed by our team. So the first one is on the requirement of guarantee letters for patient assistance for patients who are indigents or do not have money for the treatment. Next is the deterioration and underutilization of hospital equipment and facilities and how this is related to public health ethics. Third one is the ethical dilemma at ABC Pharmaceuticals, where this company allegedly pays doctors to sell their medicine and give them incentives. And the fourth one is to show the importance of research ethics when conducting research and treatment and rehabilitation centers. During the open forum, our participants gave some recommendations. The first one being on the establishment of an office level committee instead of the initial recommendation of just one. This will be more beneficial to our hospitals or units that may have hundreds, even thousands maybe, of employees in their care. Second is to include all sectors and key players in the advocacy training. So these includes agencies or local government units involved in the implementation of public health. Third is to strengthen confidentiality and data privacy and handling conflict of interest cases. Fourth rather, is to revisit and update assurances related to private practice of employees, as some medical center chiefs noted that private practice sometimes affect their actual work in the public office. And last is to increase the level of quote-unquote ethical sensitivity among doctors, as some participants noted that some doctors have this quality lacking already, and it may be beneficial to have advocacy trainings to refresh them of this quality. As for the evaluation of our overall orientation, with 207 survey submissions, the rating for the quality of our training is at 97.92%, with the rest of the categories not lower than 95%. As for the action points for our participants and their respective offices, the first one is to have an active feedback loop to the Public Health Ethics Committee and its Secretariat. If they have any dilemmas or if they have other questions related to operationalizing COI management and public health ethics in their office, they may reach out to us now that they have our number and our email address. Next is to still use the existing forms and process that we have. We mentioned that we will be updating them, but in the meantime, while these new forms and process are not available yet or not officially released yet, the existing ones can still be used. And last is to tailor fit an action plan on how they see fit to implement the public health ethics in their respective offices or hospitals. As for the future plans of Public Health Ethics Committee, we still want to continue on training and do advocacy for all of the constituents of the department. So this includes having different modes of training, so whether online or offline, and to hopefully touch the different levels of officials or staffs of the department. We also plan to review and revise existing policies related to public health ethics. And right now, we are already starting to do this, which is the Code of Ethics for Public Health, as well as the Ethics Competency Framework for our department. And last, We hope to analyze the DOH thrusts. So these includes our priority outcomes, the national objectives of health that we have, and determine whether they're ethical or not. So before I end my presentation, I would like to express the biggest gratitude to our Public Health Ethics Committee members, some of which might be already familiar to you. But yes, without them, this training wouldn't have been fruitful and eventful, and a lot of the knowledge that they bring to the table was beneficial to all of our participants. So that is the end of my presentation. Thank you and good afternoon, everyone.
Yeah, thank you, Angela. Yeah, thank you for all speakers. Finally, we finished our speakers' presentation. Now it's time to have a Q&A session. So time is a little over, so I think one or two questions is available to be answered. Yeah, okay.
Greetings to all. I'm an ISC chair from Nepal, Dr. Prerna. My question would be to our earlier, any of the speakers can be? Yeah. So ethically, what should be the gap between the pre and the post-test when we do evaluation? So how much time interval should be there between the after the training or any intervention and the post-test? So my question would be that.
Maybe that question goes to the Kasei General Hospital.
Yeah,
May you
yes.
survey the research team and the training members, right? Yeah.
Thank you your question. We training the six to 8 hours a day, and basically for day and advanced education 1 day, and the duration 6 to 8 hours.
So the gap between as soon as the intervention is over, how much time interval should we keep minimum between taking again the evaluation? My question is post-test, like if we distribute a questionnaire. So
please once again.
no, just like we do one pre-training evaluation,
Yes.
and then we give the training, and
Yes.
after that again we do the post-test evaluation. So my question is like the time interval between how much time we should put, 15 minutes, a half an hour.
Oh.
Yeah. So what is the minimum? Yeah. Ethically, or like what would be the best output for evaluation?
Yeah. Interval hour will be 6 to 8 hours.
Okay.
Yeah.
No, my
Italy, help me quickly.
between the intervention and
How much time after
end of a training.
for example, training whole day today.
Yeah.
When, for example, training 8 o'clock in the morning until 5 o'clock
Yeah.
in the afternoon. What time is post-test?
Post-test.
6 o'clock?
Like the training is over at 5 o'clock today, and I want to take
use
a
your
post-test.
translator.
Yeah. Then I want to go carry on with a post-test. So how
I
much
think
time?
immediately,
Yeah.
right after. What time? No, after when is the exam? When is the post-test?
Post-test.
At finish. Immediately.
Immediately.
Immediately after the training.
So my question is again connected to this. That is for trainings. Like we do a research training or ethic training.
I think that's the normal,
Yeah.
even in the training in other.
Yeah. So, okay. So that is ethically acceptable if we take a post-test
I
immediately.
don't think it's an issue of
No, but
ethics. I think it's
No, no,
What do
my
you call
question
that?
here arises like the connection is these are actually we are talking about only research trainings and all right now. Sometimes we do some interventions for health education, like simple health education we give to school children. So ethically, shall we do it on the same day, or maybe my question is, I don't know, concerned here, or what is the minimum time interval we should keep? 4 weeks, 6 weeks,
So
or a month?
anybody
No,
can give answer.
Can
Yeah.
I add?
No.
Can
Her,
I-
her,
Yeah.
yeah.
Basically,
Yeah.
I'm Dr. Mrenza from BP Koirala Institute of Health Sciences, Dharan.
Okay.
So, yeah, generally in this type of the workshop, pre and post test, we'll do same day.
Yeah.
Right? After the intervention, we'll do. But it depends. Like, what is your objective? Suppose you want to see the effect of that intervention after 1 day, 2 days, 4 days, like that, and then to compare, because the process of memory, no? People, how people can memorize,
Yeah.
and how people they understand how that intervention works. No? That matter of research. So depends on your objectives and designs.
Yes.
That we can do. There is a scope of that.
Yes,
But
yes.
basically, we are doing the pre-test and post-test in the same day after the intervention.
Yes.
How much they understand. That's
So that is also acceptable, sir.
yeah.
Thank you.
Thank you very much.
Yeah, this is my project limitation. This, thank you, thank you. This
Thank
is
you,
my, I cannot continue follow up how effect. This is my limitation. Thank you.
It depends on the question that you are asking.
Any,
Yeah. If the question for pre-test is just simulate the learners that what they are not knowing correctly. After the session or training, then you check them again whether the questions that they cannot answer in the beginning will be immediately understood after the training. You do it immediately. But in my case, it takes like about 6 weeks because they have to think about what they have learned, and then they try to go. This is the way that we do with adult learning. They have to go back and then see they should be trying to get the knowledge themselves and try to digest what they have learned and then do it again. So it depends on the purpose of your pre-test and post-test. If you want to know the basic knowledge, then after the training, then you do it immediately, because otherwise you will have to be knowledge will be decaying.
So there's
by the time.
there's no minimum criteria. It depends on the research and the
I think
purpose.
that
Yeah.
you have to consult the
Yeah.
educator.
Okay. Thank you so much. Thank you.
yeah. Yeah, I think survey, as far as I know, survey should be done soon after the training because of the recall bias. Yeah. If we do recall bias, it give much impact on the survey. So I think that is what your intention, your question, I think. Is there any other question? I'd like to give a question, Dr. Nishakanti. Yeah, it's really impressive. You collected many cases and it's uploaded in the website. And I'd like to ask, anybody can access that website and use the case studied in bioethics without the membership and without the fee? And
Yes.
I'd like to know how many cases you developed there.
Okay, so initially we collected, thank you for the question. Initially we collected about 90 cases. And although we were securing cases from Southeast Asia, we also have 1 or 2 cases coming from Taiwan. Well, Taiwan is still Asia. We have a few others from different regions, different people collaborating within the Southeast Asian region. So we have global North people collaborating with the Southeast Asian region, and those were there were cases included as well. Out of 90, we managed to limit to 83, depending on the scope of the case. Okay, it's fairly accessible. It's open. So if you can go to Johns Hopkins Press website, that one doesn't require any subscription or anything. The moment you get in, all you need is the DOI. So once you get in, and then you can just access the whole thing. The idea was basically open access. Because at the end of the day, if we put something as an online repository system, there has to be a reason why we're doing that. We're not going to limit it because we felt like the normal case book that is hardbound was more limited. People have to buy, not everyone can afford it. Sometimes it's very expensive because the publishers, they charge quite a lot. So this one is fairly open, and yes, you can even see it in the future getting expanded into more series under the cases in bioethics.
Yeah.
That was the idea.
Thank you. Thank you for your great effort, and it's really appreciated for it. And anybody can access that website, and it is possible to use without the membership and without the fee. It's great. Thank you. Yeah. Now this.
So we are at the last of the session. So when I was hearing the presentation, I was reflecting myself. Educating programs, particularly in public health, are quite successful nowadays. It's not in a single country, but whatever presentation we heard today, we got all projects were very much successful. For example, Micah, Angela, she presented about Philippines, and the case was very much successful. And some ideas that came my mind was inclusion of all sectors. So she highlighted on that part. So that is required in my country, Nepal as well. Likewise, decision making in local level is often influenced by politics. So this thing is also quite common. So largely, I can reflect myself that many issues are quite common in our context as well. In the other presentation, like clinical trial training for research team by Su Sui Wen, again, I got similar reflection. So there are gender differences in learning effects. Of course, we do have the similar kind of research in Nepal. So you can find this kind of results in our case as well. But there are some issues arise. For example, 2% IRB is really troublesome. So what's the reason behind it? That's the questions that came in my mind. So perhaps I have to think on that part. In other research, such as using team-based learning in clinical research education by Wei-Shen Lee, again, some ideas that reflect on my head is about the successful of the training. So 100% agreed that the intervention was quite successful. So if education programs are so successful, then why are the problems in the world, right? So that came in my mind. So in other presentation, like Professor Narapon, again conducting educational activities among research stakeholders. Results make awareness. So they have the workshop and that aware the people again. How far those awareness can be replicable to other practices, right? So maybe this is much useful to my context as well. And that problem-based learning, that also hit in my mind. So that is closely to constructivist learning, and she was trying to theorize it. And this context-specific casebook for Southeast Asian bioethics is also very much useful in our teaching learning practices. We often use this case-based method, and we find ourselves that the session was mind-blowing. But today we learned a couple of specific ideas which can be applied to teach bioethics. Thank you for the presenter. So these all presenters are equally useful, but some kind of reflection. Again, I'm highlighting that, like, if ethics and awareness programs are so successful, educational programs are so successful, then why in the real society problems really exist? So that's again came in mind. Thank you so much. Thank you for the presenters. It's a wonderful session. Thank you all.
Thank you, Professor Prakash, sir, for summarizing this session. It was wonderfully presented and putting the reflection of this session. So now we also like to thank to our presenters for the insightful contributions, and the work that you have presented here really enriched this session. Now, having said that, we would now like to proceed to our last part, that is the distribution of tokens of appreciation as a gesture of gratitude for your valuable participation. For that, I would again like to request our honorable chairs, Dr. M. Hesen and Professor Prakash Chandra Bhattrai, to come up on the stage and provide the token of love. Thank you. So firstly, I would like to call upon Nisha Kanti Gopalan to join us on the stage to receive the token of love. Likewise, our next speaker, Narapon ma'am, to join us on the stage to receive the token of love. Likewise, we have Hui Chan Lee, and finally we have Sui Won Shu. Please give them a round of applause for the wonderful presentation they have presented here. And finally, I would like to invite Professor Dr. Aljit Rai Maji, who is the Vice Chairman of Nepal Health Research Council, to provide token of love to our chairs as well. Please, a big hand to our Professor Dr. Aljit Rai Maji. So can we please again give them a round, big hand. Okay, thank you so much. With this, we have come to the end of this session. And lastly, I request everyone to have a group photo. So now we wrap up for a break, and after that we will again be back for our coming up sessions. Thank you so much. Enjoy your day.
intervention to optimize informed consent in clinical trials in India. So that's a bit of a mouthful, but I will break that down as we go along. I'm here presenting on behalf of the larger study.
Good afternoon and namaste to all distinguished delegates, dignitaries, guests, national and international speakers, participants joining us virtually, and my dear colleagues. Welcome back to this parallel session. I hope you all have a refreshing break. Myself, Rajina Sake from NHRC, and I'm pleased to introduce our distinguished chairs who will us through the next session with the theme Ethical Recruitment of Research Volunteers. We are honored to have us with Professor Dr. Arati Shah and Professor Dr. Ajit Raimazhi as session chair. Let me introduce our first chair, Professor Dr. Arati Shah. Dr. Shah is a consultant radiation oncologist at the National Academy of Medical Science, Bir Hospital, Kathmandu. With our expertise in advanced radiation oncology, she plays a pivotal role in treatment and management of cancer patients, contributing to the enhancement of oncology services in Nepal. Besides clinical practice, she also served as IRB chair at NAMS and ERB chair and member at Ethical Review Board NHRC. She also served in Medical Education Commission in Nepal as one of the directors and contributed in the field of medical education in Nepal. Dr. Shah's experience and leadership make her an influential figure in the growth of research practices in the country and remains committed to advancing the standard of medical education and ethical researches in Nepal. Now, I'm going to introduce our second chair, Professor Dr. Ajit Raimazhi. Dr. Raimazhi is a distinguished professor of pediatrics and chief consultant pediatrician in Nepal, currently serving at the National Academy of Medical Science, Bir Hospitals. With over 2 decades of experience, he has held key positions including member of the Academic Council at NAMS, coordinator of the MD Pediatrics Program, and chairman of the Institutional Review Board. Dr. Raimazhi has also served as the head of pediatrics at Kanti Children's Hospital, and he is actively involved in medical education and training, serving as the course director for advanced neonatal and pediatric life support and coordinator of the International Pediatric Epilepsy Training. As accomplished researcher, Dr. Raimazhi earned his PhD from the University of Liverpool, focusing on improving the understanding of acute encephalitis in children. His contributions to clinical care, education, and research have significantly advanced the pediatric healthcare in Nepal. So now I want to hand over to the chairs for the session.
Good afternoon, everybody here. It is so nice to be with you all this afternoon after the break. And although it is at the end of the day 1, I feel that this will be a very interesting session because we have got 5 papers, 4 in face-to-face and 1 virtual paper. And out of that also, it is a very challenging, including very challenging issues in health research ethics. The recruitment strategies of the volunteers, that also includes a variety, wide range of recruitment, like I would like to mention, like in the first paper, health research in prisons. Second will be interventional trials in oncology. Recruiting the patients in oncology also involves many ethical issues and very challenging. Third will be, as you all know, the vaccine trial. There are many issues, challenges, opportunities, and so many things in the vaccine trials. The fourth one, it includes the virtual presentation. And that will be, for many of us, it will be a newer topic, this QRI intervention in informed consent in interventional trials. And the last one, this recruitment of community intervention, which will be very interesting. So with my co-chair, Professor Dr. Ajit Raimazhi, let us have a very fun-filled, entertaining, and knowledge-based discussions, interaction, and a very fruitful session, this one. With this, I would like to invite the first presenter of this session. The topic is recruitment strategies in health research in prison. The speaker is Dr. Noor Hajwani Muhammad Jamili, Ministry of Health, Malaysia. Dr. Muhammad Jamili is the Deputy Head of Clinical Research Center at Tengku Ampuan Hospital. Dr. Noor Hajwani holds a Master of Health Research Ethics from University of Malaya and a BMBS BMed Science from the University of Nottingham, UK. In addition, she has over 5 years of experience as a medical officer in internal medicine, prior clinical research. Dr. Hajwani is a certified GCP Malaysian Certification Program trainer and holds qualification in clinical trial project management. She has been instrumental in advancing health research governance in Pahang. Her special interests include community health and research, research ethics, and studies focused on special populations. Welcome to the dais, and for your presentation, please.
Thank you so much. That's basically it about me. I'm Noor Hajwani Muhammad Jamili, representative from the Ministry of Health Malaysia, and as been introduced, today I'm going to talk about recruitment strategies in health research in prison. So this project, I'm a Mohri alumni, product of Master of Health Research Ethics, which is a very meaningful program for me, which I did in last year. So this is about the This is about my project. Is about recruitment strategies in involving prisoners as your research participants. So we all have known that prisoners are, whether it's used or they've been involved in multiple research projects, especially in health research, as early as in the World War II, where the recruitment of prisoners in the research was done unethically. It was very cruel, and then various of health research or science research have been done on prisoners itself without their consent, or whether they're being so unethical. So in that, we know that the things are getting better. We are now having a lot more guidelines and a lot more ethical codes that we are bound to before recruiting any human subjects, as including prisoners, in our research projects. So one of the guidelines that are known is the United Nations Human Rights Guideline under the Basic Principles for the Treatment of Prisoners, where it stated that all prisoners shall be treated with the respect due to their inherent dignity and value as human beings. So we shouldn't expect prisoners as being less human than us. There shall be no discrimination on the grounds of race, color, sex, language, religion, political or other opinion, national or social origin, property, birth or other status, and prisoners shall have access to the health services available in the country without discrimination and on the grounds of their legal situations. The other things that we also have the SIOMS guideline, the International Ethical Guidelines for Health-Related Research Involving Humans. Okay, which this one, the case of the dependent relationship of a neutral third party, such as a research nurse or a qualified collaborator under the International SIOMS guidelines. So institutional persons, including prisoners, they are considered vulnerable because in a confined setting, they have very few options and they are denied certain freedoms that non-institutional persons enjoy. So this has caused them to have an inherently coercive environment, whether it's indirectly or directly happens. So dependent relationship between prisoners and prison guards, which may compromise the voluntariness of informed consent. So they know when they are in a prison, they are basically, they thought that they are the lowest hierarchy of the human, where they have a prison guard above them, they have prison authority, and whether they have so lot of people above them, so which they have to abide to, so which they have to follow their instructions. So in that way, this is what we call, this is an indirectly coercive environment, that they don't have a very clear voluntariness environment that we as a people in the community have. Okay, so my projects, we focus on the low and middle income countries, and then just stating on the statistics of the world prison population globally, there are more than 10.7 million people in penal institutions globally, and the total numbers of prisoners has increased worldwide. This has been leading to the issues of overcrowding of prisons, and there's an unmatched investment in capacity and resources. So the place for prisoners are limited, the capacity are limited, but the numbers of prisoners being put in prisons are increasing over the years. So same thing that's happening in Malaysia. So this is I'm only showing the numbers of Malaysia. So we have over 76,000 prison population of total, with prison population rate of 229 per 100,000 of national population, and the occupancy level based on official capacity is 113.5%. And over the years, we can see the numbers is gradually increasing. So it has caused, although as a researcher, we might have thought that the numbers of prisoners, the increasing numbers of prisoners might be, in a way, an advantage to researchers in a way to recruit them as a part of our research participants. But actually, living in the prisoners is the overcrowding issues is the main issues of prisoners, basically globally. Okay, so to recruit prisoners in health research, we have to bear in mind there are a lot of ethical issues. So we need to have certain strategies to make sure that our recruitment process is abiding to the ethical principles, abiding to the guidelines internationally and also regionally. And also we do not deny their rights as a human being. So in this presentation, basically my objectives is to identify the recruitment methods for health research involving prisoners and to discuss the ethical issues when recruiting prisoners as the research participants. So what I did was I did a scoping review of papers that conducted research involving prisoners as their research participants. And I read each and every one of them, and I read what methodology they had, what recruitment strategies that they did, and how it abides to the ethical principles, and how does it agree to whatever human rights principles that we are holding to. So this is the framework that I use, basically the PIO framework of prisoners, recruitment strategies and protective measures. And this is my results. I'm just going to scroll through. Basically, I found over 2,300 papers, and I shortlisted, included in this review is only 46 papers. So from these papers, these are the numbers that we have. Those research coming from Ethiopia is the highest number. There were 8 research from Ethiopia, and most of the numbers is around 1 to 8 number of research conduct in these samples. And in terms of the sample size, okay, because Ethiopia has higher numbers of research projects, so Ethiopia had higher sample size lah, in a way. So it's around 1,100 sample size of subjects being recruited in those research projects. Sorry. Am I too fast? Okay, so in terms of their sampling method, most of them will choose non-random sampling method, which is a total of 27 papers did a non-random sampling method, while 18 others are random sampling method. Okay, in terms of non-random sampling method, they choose the purposive sampling to recruit their samples. And then one of the strategy that did is they also do a snowballing, which is specifically mentioned in certain in a few of the papers. They did a snowballing to reduce the effect of selection bias from purposive sampling. So this is very important because snowballing, selection bias, especially in a prison environment, in prison community, can be quite a big issue, especially when you have different stakeholders, not just the prisoners. You have the prison authority. The prison authorities have their own say of whoever is going to be in the research, whoever is not, right? So we want to reduce that. They want to reduce. So snowballing is one of the technique that can be used. And then also, for the recruitment also, they also have a delegated person in charge as a spokesperson for the project. So even though in a project, we must have a team of a number of teams, but there always have been one research assistant that works truly in the prison at the site itself, that be the spokesperson, that will be the how do you say, the person in charge of everything, that will communicate with the prisoners itself. So the prisoners will not easily trust anyone from outside getting into their prison, although they are prisoners. So this one person that is delegated as the most important person in your research team is the one that will be the main person to communicate within the research team and also the prisoners itself. The other thing is that they also have some of the paper, they have a delegated prisoner to be in charge as the team member. So that person, that prisoner in charge is the one, usually is a good behavior prisoner that will help with the snowballing technique, that will help to spread out the words of the research being conducted in that site, and then it will help you out in terms of the recruitment process itself. So these are the techniques being used. Also taking into account the issues that can happen or could happen in the prison environment. Power dynamic is something that we cannot actually avoid. Okay? In a prison, we have a prison authority, we have prison guards, they have a say, they have a big say also. And then this hierarchy of power dynamic, this is just not just the formal that we all know, the prison authority and the prisoners. We also have the informal power dynamic, which there's no black and white on it. So it's like watching a movie about the prison life, right? So there's certain prisoners are a bit higher up than a certain prisoner. So there's something like that lah. So we have to acknowledge the superiority of the former prison officers, that they are in a way above prisoners, and applied it in research. So this a project by Junaidi in Indonesia, they acknowledge that, and they use that. They recruit the prison officers to be part of the team, and they that's not the right word, but the prison officers help to conduct the research activities and involve the prisoners in their research. Okay, so that's another technique that I think is quite brilliant when I read through it. An informal prison hierarchy system, this is specifically mentioned in several papers, both in Kyrgyzstan, Okay, so this is the one informal prison hierarchy that I talked about. It is in Kyrgyzstan. It's called an obschak. So anyone from Kyrgyzstan, if no, right? So I don't know the meaning of obschak itself, but yeah, obschak is mentioned in those papers. So it's basically they acknowledge the informal prison hierarchy. However, in all of these papers, there's not a word of coercion being mentioned. I don't know whether it's indirectly being experienced by these papers, by this project or not, but no coercion words are being mentioned specifically. Okay. So I'm gonna run through a bit fast. So this is basically summarize the recruitment preparation that we can, in a way, apply in if you are doing a research project involving prisoners as your subjects. So you need to engage with the prison authority, engagement with the prison community, and empower the good behavior prisoners to train them for the research project, the conduct of the research project. So this engagement with the multiple stakeholders is very useful, and you need to make sure that the engagement, the collaboration that you have with these stakeholders is strong enough to make sure that whatever that you do is being approved prior to whatever activities of research that you are doing in the prison site itself. I think that's today. I'm gonna skip until the conclusion. Study methodologies and provision safeguards were contextually based and may differ accordingly. And research stakeholders need to be sensitive and aware of the ethical challenges and balance and engagement with prison community and authorities are very important in your research involving prisoners. I think that's all. Thank you so much.
Yes.
Yes, please.
It's a Russian word. We talk about cohort, right? Common group, common treasury. Obshak is that. So common group of criminals who are there in the prison. Okay, that's Obshak means that. It's a Russian word.
Thank you so much.
Thank you.
And you are from Russia?
I'm from, you're asking me?
Yeah.
I'm from Mumbai, India, from the Tata Memorial Center.
Dr. Ganapati has started with the question answer, I suppose. So we would like to take one or two burning questions immediately, so any questions from the audience? Otherwise, I'd like to thank Dr. Noor.
Thank you for such an excellent presentation. I would like to ask you, how do we cross-check the reliability of the answers of the prisoners, whether they have not been questioned or threats to answer that question? How do you check the reliability in this? Yeah.
All right.
Because it's prisoners, prisoners.
I know. Yeah, I know what you mean.
Policemen and
yeah.
soldiers.
Actually, there's can I open that slide again? Actually, due to the time, so I focus on my presentation on the recruitment strategies. But from that, actually, there are several techniques that you have to make sure that whatever that we collect, that data collection is from the prisoners are reliable and it's not being biased or it's not being how do I say, affected by the authorities or anyone else, right? So this is the part that is very important. That the other, apart from the recruitment strategy, you also have the strategy to make sure that you need to have a space that allows them to be very truthful, and that including having a space, a very private space, even without the existence of the prison guards. So some of the paper has a room divided by a glass door with a prison guard outside can look inside but can't hear anything. So basically, whatever conversation between the researcher and the prisoner remained private and confidential. So this is one. So those are one of the strategy that they use lah. So apart from having making sure that your informed consent is properly being conveyed, that everything is for us only, not being taught, not being shared with the prison authority straight away, and it has to be anonymous, all those kind of things that I think all of us knows, right? But for the prison side, specifically, have a room, just the researcher and prisoner, audio taping, audio recording, not video recording, and glass door is a great idea with the prison guard outside. It's for the safety of the researcher, also for the protection of the confidentiality and privacy for the prisoner, I think. Yeah.
Thank you, Dr. Noor Hazwani, for your nice and informative presentation.
Thank you. Okay, we have next presentation, very interesting. What motivates volunteering for interventional trials in a tertiary referral oncology center in Mumbai? It's Dr. K.V. Ganapathy from Tata Memorial Hospital, Mumbai. Dr. Ganapathy from India is a dedicated member of the Institutional Review Committee at the Tata Memorial Hospital in Mumbai. He's serving as a representative. Dr. Ganapathy shares insights and different perspectives to ethical decision making in clinical research. He holds a PhD in interesting subject, adolescent psychology, and has been associated with ethics committee since 2015. Dr. Ganapathy, please, the floor is yours.
All right. A very good afternoon to all of you, and I insist that you all have to say good afternoon to me. I want you to open your eyes and mouth and say that quickly. Good afternoon. Yeah, that's better. I don't want to feel as if I'm talking to a wall. I want to feel that I'm talking to human beings, okay? Now, I belong to Tata Memorial Center, and this is perhaps Asia's largest tertiary cancer institute. And we see a footfall of 1,44,000 patients last year. And almost 38 to 40% were palliative care patients, and that's where I do my end-of-life and grief counseling. So every day in the afternoon, I have the misfortune of giving the bad news to the parents. I work a lot in pediatrics and adolescents. And, also sometimes the adult patients have to tell either the husband about the wife or the wife about the husband. That's my job. And I'm also a member of institute committees at CERSED, both at Tata Memorial Hospital and Indian Council of Medical Research. Now, this was one of the days, the person who's responsible for this research, Dr. Nitya, who sits in the other hall for her sessions, she is the embellished chairperson of my ethics committee, and we both had the opportunity of monitoring administration of informed consent, and everything that the document says, the sanctity of the document, knowingly or unknowingly was not followed by the principal investigator while he was administering it. So the question is, while we all have a beautiful document which, enumerates all the elements, privacy, confidentiality, purpose of research, risk and benefit, all those things, when it comes to actual administration of the consent document, while we are in the OPD with can somebody help me? I told you. You please stand here and do it. Yeah. So what do I do? Okay. Right. Right. Okay. So that's the background that I come with. And as I was telling you, both of us went across to see how this principal investigator was administering the document. And that's when we realized, a lot needs to be done. And today's conference has thrown a caveat that how ethically responsible we should be while conducting this trial. Okay, we are supposed to maximize the benefits through ethical conduct, but justifiably there are high volume patients, very, very bad socially, economically disadvantaged patients, lower level of literacy, okay, coming from all over the country to stay on the sidewalks and the footpaths of the hospital. And we are talking about 300 odd MDs who are doing their residency, and therefore that many studies happening, and therefore every month when there is a ethics committee meeting, we review nothing less than 30 to 40 initial review. So that it is not a justification, it is not an excuse, but I'm just trying to familiarize you with the kind of difficult condition that we are working. And as my previous speaker said, you don't have to be a prisoner to be vulnerable. I am PhD, I can still be vulnerable if the surgeon is going to take me under his knife. The only difference is I'm quasi, because I can perhaps ask him question and understand what he says, while the others might not be. Okay, so that doesn't make me any less vulnerable. So let me go straight to the study. So based on the observation that we did, we saw that how the principal investigator, giving the benefit of doubt to him, comes under the pressure, and then he has to do this study, and therefore he doesn't have so much of time to explain. What we have now decided post this is also there in the slide, so you can know. Okay, so when we talk about any clinical trial, we're talking about three important tenets. One is all informed consent. Everybody knows, right? It must clearly, in simple, understandable, native language, it is supposed to talk about the objectives of the trial, right? What is a clinical trial? It is nothing but a research study that tests any medical, surgical, behavioral intervention in participants and designed to learn and find new and effective treatment approaches or less harmful side effects than the existing treatment. Now with the new age therapies of we have immunotherapy, targeted therapy, we've got so many advancement that is coming in. However, when you talk about what Christina was talking in the other room before lunch, post lunch, that the diagnosis is on the patient. I have a cancer in my gallbladder or my pancreas in a particular site, but who's suffering? The entire human being. So do we look at this trial of a patient who is a human being who has a psycho-socio-spiritual dimension apart from the physical part, which makes him a human being, and that human being suffers. So how much does this clinical trial really take that into account? My due respects to all the doctors who are here. I'm not belittling them, I'm not deriding them, but honestly, this is a reality. Okay, that's where I come in, and I kind of today train doctors and nurses on how to look at the human aspects of while your treatment is on. So secondly, who's the trial participant? How vulnerable, how educated? When you do the inclusion criteria, who's the trial participant? Anyone who takes part in a clinical trial that includes healthy people or people with disease or a condition that is being studied. Okay, so I don't know whether many of the doctors, investigators would really actually tell the patient that is different as a clinical trial participant, clinical trial subject is different from the patient. That clarity, I don't think many of them get it, okay? That's what one of the results that pointed out, we'll talk about. And then the next is, how voluntarily is the participation? Okay, and again, the result that I'm going to share with you is going to be talking about how much that voluntariness is compromised. Okay, and then the next thing is, there are four main pillars in this thing that I'm not going to get into because we have been battered by these four things. Everybody knows about it, but it's important when we're talking about how we are going to empower the trial subjects, that it is a contribution that they're making to society, and how important it is for the trial coordinating team and the principal investigator who is responsible for the trial, not just from the point of view of publication, but whether he is following all these four principles. So that is extremely important. It's all there, but why it is followed and whether it is followed or not is very, very important. Okay, and so we come to the most sanctified document. Okay, you call it Bible, you call it Quran, you call it Gita, and whichever, it is informed consent. Now everybody knows what is an informed consent, okay? So there are various branches. It is the main source of information. The trial subject knows why is he invited to participate in the trial, what is going to happen to him in the trial, and what is not going to happen to him in the trial. Does he know about the risk of participating? There is no inducement. It is so blurred. The PI is justifying his study because he says it can improve, or there is a possibility that it might improve the existing care practices, and the vulnerable, not so educated patients will want to take the meaning as, oh, that means only sees selective perception, only sees the one word improvement, and they say, हाँ मैं ठीक हो जाऊंगा, I'll get all right by that. Okay, so therefore, are they really informed? Do they have the choice of saying no or yes? And why are they saying no or why are they saying yes? Okay, so therefore, the question is how informed. So every informed consent document has got aim of the research. Why are we doing this study? How is it going to be beneficial, safe, and efficacious? Both it's going to address. The new drug, how much, what kind of toxicity is going to throw, and therefore what is going to happen to the quality of life of the patient. We are talking about quality, while the doctor talks about quality of life by going from a biological model of treatment to a biopsychosocial model of treatment, right? We, as an ethics committee member, it's equally our responsibility to ensure that the patient or the trial subject who is being enrolled is also aware that whatever is being done will not hugely compromise his or her quality of life. And to a far extent, their activities of daily living will be kind of preserved. Okay, we are not merely looking at the longevity. Then we are talking about methodology. I mean, in the informed consent document, we are supposed to say what kind of research methodology are we going to do and why are we doing. It talks about sampling, your other methodologies of the research, qualitative, quantitative, everything. Then we talk about risk and benefit. By participating in the trial, what are you risking? Now, here comes the vulnerability. I am the only wage earner of my family. I'm 19 years old. I've just got into a relationship with a girl, and we're promising great futures. Okay? Or like one of the lung cancer patients said, he said, doctor, in the palliative care, all you do is, I have got a 3-year-old daughter, I want to play with her. And he had severe lung metastasis in the ribs and the bones back. He was not able to hold his child. He said, allow me to do that till I'm alive. You know, that is the kind of activities of daily living one person is doing, apart from your normal bathing, toileting, washing, everything like that. So, are you explaining this risk? And of course, the benefit. Who has the leverage? The physician who's doing it, he has a leverage, or the patient who's going to be participating in this has a leverage. That has to be very carefully understood. Compensation, okay? And then again, will that compensation be seen as an inducement? So everything you take into account the background of their literacy level. And then we're talking about the reimbursement. Is the patient getting his money, whatever he is entitled to, is he getting on time, every time? Now, these are the 3 important factors. All these things you do ethically while conducting that research, starting from administering the informed document, but there should be no coercion. Nobody wants to coerce, but how does a person understand, right? You are examining the patient, but it's the patient who says what hurts where. It is his experience that we're talking about. That's the subjective thing Christina was talking about, qualitative research. And not only you have Edmonton symptom scale and you have a, blah, 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 so many other things, and you have mathematical calculation, and you say, no, it can't be, right? It's not working that way. So non-coercive. How is he understanding the compensation? How is he understanding, and typically for pharma trials, huge. And how is he understanding the reimbursement? Okay, no inducement, and above all, it has to be voluntary. Okay. So the challenges. I think I missed out one slide. Yeah. What are the challenges here? Yeah. Low middle income country, LMIC, where 64% are experiencing financial toxicity. I just happened to present a paper in one of the conferences in lung cancer year in review, and I was appalled to see the total number of lung cancer patients in India vis-a-vis the financial toxicity. Not leave alone the treatment-induced toxicity that they've got, right? They are being told to spend on immunotherapy because it's going to prolong their life for 2 years, but nobody gives a damn to what about the caregiver's distresses. Right, in a 5-by-5 room, there are half a dozen children, there's this patient, you're talking about immunotherapy, and what is the quality of life of the caregivers? Nobody has really thought and nobody has really given their this thing to it. So low middle income countries and high volume patients and poor socioeconomic status and very high rigid beliefs coming from religious influences and false expectations. And that's exactly what the result is telling us. What made the volunteering motivating for them to get into clinical trial and what was seen in the form of the result. Okay, so, and wrong perceptions about what the clinical trial is. So, it is very important in that vulnerability also there is an empowerment. Because of their vulnerability, the study is happening, they are not saying no, but whereas the other side, the people who are conducting the trial are getting empowered because of publications, because of their whatever name, fame that comes along with them. So we have to, I leave the audience over here to think and reflect how ethical the whole thing is. The crux is, are participants clear that they are trial participants, sorry for the spelling mistake, and not patients when they consent to participate in a clinical trial. So here we go to the methodology, okay, the study. The aim was to understand what motivates volunteering for interventional trials in a tertiary referral oncology center in Mumbai. That's my institute, Tata Memorial Center. Okay, and rationale is to explore the patient's understanding of what the clinical trial and do they really make informed choices? Are they really informed? That's what we wanted to explore. Okay, and the study went like this. The methodology was the trial subject who was invited to participate in this study was already enrolled in one interventional study. Okay, it was very important that trial subject is a part of a pre-existing interventional trial because that's what is going to get an answer to a question. So when they were invited to participate in our one question framed qualitative analysis, made them eligible to participate in our study also. Okay, so exploratory study and ethics committee approved and CTRI registration was completed and sample size 120 non-probability purposive sampling. We had patients across the DMGs. In Tata Memorial Center, the disease management group, which handles different patients, goes by the site of the cancer. So head and neck is from here to here. GI, completely from your, gallbladder, I mean, your esophagus to stomach to anal tract. The whole thing is taken into consideration. Then, of course, lymphoma leukemia is a different thing, but all solid tumors are categorized based on the organs, and that's how we said that there are interventional trials happening in all the disease management groups. So let's have 10 participants each from each of the trial. Okay, so consenting process of participants in interventional trial already there, as I told you, and all participants administered Kupuswamy scale for slotting them in the proper economic category of higher, middle, and lower income class. Okay, we wanted to see whether this has any associations with why the trial subjects are participating. You'll see the result for yourself in the next slide. Okay, single interview questions. What motivates you to participate in this trial? Spoken in vernacular languages. We had patients coming from Hindi land, Maharashtra land, Bengali land, Gujarat land. So we had all these languages. Unfortunately, I'm conversant with all the 4 languages, so I managed to do this interview. Now the results and the themes. Very interesting. 3% of the population said that they are part of this trial because of the hospital image. Tata Hospital ka bahut bada naam hai, is very famous, and we know that if they are doing something, it's only for our good. 3%. Very interesting, right? Pampering your ego, right? The second thing was treatment compliance, that they understood that there is a new drug that's going to be administered on them for better care practices. So 3% said that my treatment will be incomplete if I don't participate in this trial. And all this was audio recorded, and that's how we have heard the audio again and again when we transcribed and got the thing. And knowledge about the disease. 6.6% said many of them did not understand why cancer, why in this place, why after chemotherapy it has still metastasized, why now my treatment is going to be stopped, all those things. So they said we wanted some knowledge of disease so that we can talk to our family people so that they are careful about it and they don't get it. And then trust in doctors, implicit faith in doctors. Now this is such a wonderful thing. 11.5% said the treating doctor told me, so I did it. Because I've got, now here is the first bias in the sampling. This treating doctor has seen you 4 times earlier in the OPD. 5th time, he after one chemotherapy or something, he's going to experiment a new drug on you. So he calls. So I have already broken the ice with you. I'm very comfortable with you. And therefore, it becomes a very formal conversation. He doesn't even ask a question. Doctor Sahab, just tell me where I have to sign. I'll sign it. He doesn't even go through. The clinical trial team, how much of it explain? Our doctors made you understand everything, right? Not everybody does that, but there are few who are doing it. So what is very good, doctors, this thing, but it's not appropriate for clinical trial. Okay, altruism. Very interestingly, 21.66% said, I may live or I may not live, but if I'm going to be the conduit for the society to benefit, I'm so happy. And surprisingly, that Kuppuswamy scale or education level, I had PhD participating here who said only for personal benefit. I had an auto rickshaw driver who has not seen the face of the school. He said, "Mere wajah se kisi ka bala ho gaya, because of me somebody is benefited, I'll feel worthwhile in this life." Like that, there were few. So altruism, because India is a land of altruism. We are so God-fearing, we are so reared in this kind of ethical, value-based living, but we did not see much of that here in the clinical trial. Okay? Now the best thing is personal benefits. I will be closer to doctor, my treatment will happen, I will have easy access to doctor, I will get the best of medication, therefore I will be cured, and therefore I will be living longer. These were the narratives. How many percent? 55%. Right? So this is the reality when we are talking about administering informed consent. Everybody does this formality religiously, but how much the person has understood is a big, big question mark. Okay? So therefore, the study also showed there was no direct association between socioeconomic status and the nature of response that the individual gave. Okay? Only a small proportion of patients participated, thought this participation is an opportunity to contribute to the society, which is indeed very sad. Okay? So finally, conclusion is, this novel study does provide a roadmap for us to understand how the patients in a tertiary cancer center is perceiving clinical trials. A structured education program considering the level of literacy, comprehension, and recall can be designed to address the lack of awareness. And we already are doing a pilot study where we are giving the informed consent and calling the patient at his or her convenience after 3 or 4 days and just telling them, like a pre and post. I mean, we tell them there's not an examination or something, but let's see how much. So that if we need to re-educate them, so be. The purpose is that they understand the purpose of this participation very clearly. And finally, concerted effort is needed to educate the trial coordinator and the trial team and the trial participant along with. Okay, so what is the future course of action? Every quarterly, we have something called as grand round, where something like this that we have, you can call it path-breaking or some discovery that we find in the care practices is presented to the top-notch management of the hospital, the main decision makers, and requesting them to present the findings of the study to the hospital and design a program to improve informed consenting process. And the plan that we have got is that since we have got 2 laypersons, 2 social scientists, that we will take a turn every 2nd or 3rd month to be a part of a clinical trial informed consent process administration, so that it is not to find fault, it is not to audit, but ensure that the patients are not taken for a ride, or nobody has an intention, but they are taken for a ride. And finally, informed consent sounds so easy in principle. Religiously, everybody's signature is there, date is there, blah, 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 blah is there. But in spite of that, you saw the response, what has happened. While the surgeon explains the balance of risks and benefits, the calm and rational patient decide what he wants. Just like going to the supermarket and choosing from the vast array of toothbrushes one can offer, right? And however, the reality is very, very, very different. So be informed, be empowered. As I get off the dais, I only want to say one thing. I read Tavistock's some paper. He says, there is no service without a research. There is no research also without a service. But if you do that without ethical responsibility, the essence is lost. Because both the service delivery and the research is futile, redundant, and doesn't help anybody. Thank you so very much.
Thank you, Dr. Ganapathy, for such an insightful presentation on factors motivating recruitment in clinical trials. I think we just have time for one question, if anyone has any question. Yes, please.
Thank you, sir, for wonderful presentation.
I can't hear you. Something wrong with me.
Thank you, sir, for a wonderful presentation. Myself, Dr. Amran Jha from BP Koirala Institute of Health Sciences, Dharan. It is eastern part of Nepal.
Okay.
So this is just my curiosity, not a questions. So the questionnaire that I have used in this research is self-structure, or it is already in the public domain that is published. And the second one is, you have told that you have translated into different 4 languages, as you know, the different languages. So have you tested the validity and reliability while you are translating that questionnaire into different languages?
Yes, yes. Number one. Number two, I also do after I have recorded my this thing, I have invited one of the clinical research team who's also part of this study to objectively hear what it is, that whether he or she has understood or not understood. Yeah, common person. Yeah. Thank you.
Thank you.
Thank you.
One more question I would like to ask is, how do you differentiate coercion from compensation? Is coercion from compensation? Like, is there a limit? If you're giving more than what is required, then it's coercion and just sufficient to carry on with whatever, they have lost as compensation. And another thing is, if you had taken socioeconomic status and correlated with the outcome, had it been education, probably, the trust on doctors would have gone up.
Yeah.
Then, personal decisions. Would it be different, the outcome?
So if I understood correctly, sir, you're asking question number one is compensation. Yeah. Second one, I'm a little confused. What did you ask?
You correlated with socioeconomic status with Kopuswamy scale. I was saying, if you had taken education as a scale, level of education.
We are going to do that in the next.
Okay.
We are going to do that next. And
Thank you.
Of course, I hardly get a question on compensation. Yeah, I hardly get it. I am getting questions on compensation only by NEH aggregators when they come and interview all of us. As a community representative, there should be fire in your belly how the compensation is done. So we only rational NDC's formula or whatever it is, but honestly, I've never had a question and never had a chance to be a part. Thank you. Thank you so much.
Philippines General Hospital. Third presentation by Audrey John Lavilla, MD, Philippines General Hospital. And this topic of presentation is titled Role of Community Recruitment in Vaccine Trials, Challenges and Real World Solutions in a University Research Center in Philippines. And I would like to speak about a small introduction about him. He represents the esteemed University of the Philippines, Philippines General Hospital. Audrey John Lavilla contributes significantly to advancing medical education, research, and clinical practice in the Philippines, and that dedication reflects the why it is like this. And that dedication reflects the institution's commitment to excellence in healthcare and the betterment of community health outcomes. So now he'll be talking about very important topic in vaccine trial and all the issues in it.
Thank you very much for your kind introduction. So good afternoon, everyone. I am Orly John Lavilla, a medical doctor by profession and currently a sub-investigator from the University of the Philippines, Philippine General Hospital. And I'm here to present to you Yeah, there. The vital role of community recruiters in vaccine trials, challenges, and real-world solutions in University Research Center in the Philippines. So, but before I begin, I would like to acknowledge the other authors of this presentation, most especially the principal, the main author of this presentation, Dr. Ralph Villalobos, who can't be here today, and the other authors, Dr. Don Go and Dr. April Nepomuceno. So, participant recruitment remains a critical factor in the successful completion of a clinical trial. So from a perspective of as a clinical trial site, failure to meet anticipated enrollment goals within the period prescribed in the clinical trial design can cause premature termination and reflecting negatively on the fulfillment of investigator responsibilities. Standard approaches to recruitment issues cite trial design and protocol development, trial feasibility and site selection, and communication as the primary determinants of a successful recruitment plan. However, the experience during the COVID-19 vaccine clinical trial expanded these issues. So let me begin with our, thus through this presentation, I would like to share our experience and the lessons we've learned in addressing a subset of irregularities in a clinical trial recruitment, particularly in vaccine clinical trials that aren't explicitly covered and addressed in the current good clinical practice framework. In this presentation, I'd like to introduce a new stakeholder in the community, the community recruiters, their roles, the challenges encountered, and the solutions we implemented to these challenges to ensure trial success. So let me first introduce to you our center, or my site in our institution. It's the University of the Philippines Philippine General Hospital, or UPPGH. It's a national university of the Philippines. It is the biggest government tertiary hospital, catering to more than 600,000 patients yearly with 1,500 bed capacity, and is the only national referral center providing direct and quality patient service to millions, actually, of Filipinos all over the country. It mainly functions as a service, training, and research institution. So to provide a context, the COVID-19 pandemic brought in to the spotlight the conduct of clinical trials. As you all know, at the height of the pandemic, there's been a surge of COVID-19 related clinical trials globally, including in the Philippines. But I would like for you to focus more on the COVID-19 vaccine trials, as most of these trials were community-based, thus requiring healthy volunteers. These trials were usually big and requiring large number of participants or subjects within a short period of time. Thus, this conduct of these trials actually necessitate careful, strategic planning by sites. So, the first two COVID-19 vaccine trials in the Philippines, including the first one in the, on this table, received approval to conduct their trials around late 2020s to early 2021, which is the peak of the pandemic. Our site took part as one of the clinical trial sites. So overall, our site actually conducted a total of 5 COVID-19 vaccine trials with a total of 8,900 participants enrolled, with breakdown of number of participants are as follows. I would like you to focus on the first two rows, the phase 3 vector-associated COVID-19 vaccine trial and the phase 3 inactivated SARS-CoV-2 COVID-19 vaccine trial. As these two COVID vaccine trials conducted by our site had a very stark difference in recruitment strategy. So the first trial is the phase 3 vector-associated COVID-19 vaccine trial, where we enrolled a total of 318 participants, most of whom were professionals from the healthcare sector, like doctors, nurses, but some participants were not part of healthcare professions, like lawyers, those who work in corporate. Recruitment mainly was done here in this trial through word of mouth. On the other hand, we have a phase 3 inactivated SARS-CoV-2 COVID vaccine trial, where we were allotted around 3,000 participants. Most of the participants enrolled in the study were volunteers from nearby communities in Manila, coordinated through community recruiters. And actually, in the succeeding trials, as listed here in this slide, were done mainly through coordination with community recruiters. So currently, we have 2 ongoing vaccine trials, not COVID-19, but however, they were already completed recruitment and enrollment and are about to actually have their final study visit. Although the number of these participants in comparison with the previously shown COVID-19 vaccine trials are far less in comparison. So these are still high, and doing this without the collaboration of with the community recruiters would impede actually enrollment process. These experiences actually underscores the importance of a new stakeholder in the clinical trials, the community recruiters. So I've been talking a lot about community recruiters, but what are community recruiters? They are local individuals, maybe a barangay captain or barangay councilor or barangay official or health worker. They are who assist with the site with participant recruitment. They are valued for their connection and strong network within the community. And usually, in practice, their role is informal and not officially delegated, as deemed not having sufficient level of education for GCP training and often motivated by financial incentives. So although I've highlighted in my previous slides that the importance of community recruiters, our collaboration with them have not always been smooth sailing. So multiple problems arose, including issues of recruiters, getting some money from the participants' travel allowance, multiple enrollments, and document falsification, which will actually be dwelling on individually in the next few slides. So first problem was the recruiters getting some money from the participant travel allowance. As I previously mentioned, most community recruiters are financially motivated. Based on anecdotal reports, sometimes they arrange internally with their recruited participants to get percentage of the subject's compensation. So as a response, the site dedicated incentive and dedicated budgetary incentive allocated specifically for the community recruiters. So the second problem would be multiple trial enrollment of participants across different sites. A number of reports we received or an anecdotal experience suggests that these recruiters will sometimes encourage some of their participants to enroll in multiple trial and/or trial sites. So in fact, the IRB, or our local IRB, released an advisory wherein all investigators were instructed to, one, first establish site control procedures for detecting false documents that may be used in enrollment of the subjects. Secondly, actively contact individual clinical trial participants to warn them against predatory recruitment practices and the dangers posed by multiple clinical trial enrollment. And third, creating vetting procedures for community recruiters and formally accredit these recruiters' affiliation with the clinical trial site. And to facilitate accountability, and lastly, to closely monitor for similar occurrences and reports such into the local IRBs. So other actions by the IRB included they held meetings with the clinical trial stakeholders, including the principal investigators, the sub-investigators and sponsors, SCs, and the CROs from various ongoing clinical trials in the PGH. So during those meetings, the following were proposed, including creating a database for all participants enrolled in clinical trials, and formalizing community recruiters by undergoing rigorous training and officially delegating them as part of the site staff. So what are our actions for the stated problem number 2, which is multiple enrollment of clinical participants? As a response, our site started off by immediately contacting each individual participant, as we believe that participating in multiple clinical trial sites will compromise subject safety and data integrity of the studies. In the event that during the phone call, we detect cross-enrollees, they were notified that they will be continuously followed up for safety monitoring. And as for the sponsor, they were informed of such occurrences, and the investigator recommended removal of the said participants from the efficacy analysis. So during the phone call, what we asked were whether they are currently, we asked the participant whether they are currently and or planning to participate in another clinical trial outside of the trial they are currently enrolled in. And second, whether they are part of the same clinical trial in another site. And third, whether they are involved in any fraudulent activity or, to the best of their knowledge, aware of any fraudulent activities committed by the other individuals in relation to this study. So in addition, we also did other site actions to mitigate the issue on multiple trial enrollment. So the site asked the community recruiters the following. First is to sign a binding contract, which indicates that they will be working closely only with our site. Second is to file an affidavit to avoid these fraudulent activities. And third is for the community recruiters to undergo GCP, study protocol and community coordination trainings. And lastly, to include them in the delegation log of the clinical trial. Another concern is the report that there are several such community recruiters are resorting to falsification of trial subject documents, including government-issued IDs such as birth certificates. To combat this, the site, since the beginning, the site, we employed a strict standard operating procedure of verifying the accuracy of the identification documents, including requiring at least 2 identification cards, and verify them through physical and visual inspection, and if available, using verification apps. While with the IRB's approval also, instructions, we revisited enrolled participants' profiles to identify any suspicious irregularities. Looking ahead, community recruiters will focus on working exclusively as a community coordinator at the clinical trial site and shall not engage in any recruitment or coordination of activities for any other clinical trial site, whether directly or indirectly, ensuring accountability through exclusive collaboration with a single clinical trial site. And also help coordinate, including reminding the participants of their next scheduled visits, particularly assisting participants and the site during surveillance visits or follow-ups. And also to coordinate regarding patients who cannot be reached or contacted. So in summary, community recruiters are actually indispensable to the success of vaccine trials, especially in challenging circumstances like the COVID-19 pandemic. While their involvement presents challenges, the investigator cannot address this problem alone and instead needs a collaborative approach that involves all the GCP stakeholders, perhaps including other regulatory agencies. Clear policies, training of community recruiters, and monitoring can mitigate risks and enhance recruitment efficiency. Our experience in UPPGH demonstrates that potential for refining recruitment practices in clinical research. By sharing our experiences, we are hoping that we also learn from the participants of this conference regarding the best practices which we may adopt in our site. And with that, I would like to end my presentation. Thank you very much.
In this short time, Orly Zone has mentioned about so many things, so many issues, as well as problems and problem-solving solutions also in his presentation in the vaccine trials. So there might be many, many questions arising. I'd like to...
Thank you. Thank you so very much, Doctor, for that nice study, actually. But if you go to your question slide, that is, I don't know what others feel about it, those 4 questions you have asked. Yeah. I found question number 2, 3, and 4 are a little leading.
Oh, can you flash?
Can you show the slide, please?
Yes.
They are not simply open-ended, they are leading questions to me. I don't know how many of you agree to that. They are, right?
Yes.
Okay, for example, if I'm a participant, if you're going to ask me, to the best of my knowledge, am I aware of any fraudulent activities committed by other individuals? I'm going to say no. I'm not going to say yes. Probability is high. Are you personally involved in any fraudulent? Definitely, I mean, 80% I will not say. And how does this yes and no help you in the study? Okay, the answer could have been either yes or no, right?
Yes.
How does it help you in your study?
Well, this is actually in response to the advisory provided by the local IRB. So we already have knowledge with regards to cross-enrollees. So we're only verifying whether the participants have indeed cross-enrolled in another site or in another trial. So there are really targeted questions and direct. Yeah.
Sorry, that was my take. Thank you so much.
Okay.
Yeah.
Any other questions?
Yes, we indeed find participants who actually divulge that they are participating in another clinical trial site. Yes.
So I have got one query. You mentioned about the professionals as well as the community volunteers for the recruitment.
Mm-hmm.
So was there any difference? What difference you found in both?
Well, mainly.
Both of them are quite different.
Yes. Well, the first, if you saw the first one is mostly word. Recruitment was through word of mouth. While on the other hand is through community recruiters. So the stark difference is actually that these two, the word of mouth is actually at a slower pace than compared to your using community recruiters in actually trying to get participants to be involved in the clinical trial. And also, yeah, that's it, I think.
Thank you so
Yeah.
much. Thank you for the nice presentation and many useful things in that.
Okay. Now we're there for virtual presentation. I hope it is ready. Okay, it is also an interesting topic. It says feasibility of an adaptive quantity recruitment intervention to optimize informed consent in clinical trials in India, Orion I study. It's a virtual study. The speaker is Dr. Sangeeta Paramasivan from University of Bristol in United Kingdom. Dr. Sangeeta is a senior research fellow in qualitative research methodology from Bristol Medical School, University of Bristol, UK. Over the past 15 years, she has been working on trials methodology research, particularly on optimizing recruitment and informed consent in clinical trials in the UK. She has also been working on similar areas of research in India and is keen to support trials methodology work in other low and middle income countries. We can start the presentation.
A senior research fellow at the Bristol Medical School. I'm a qualitative research methodologist. I'm here to speak about the Orion I study, where I stands for India, and I'm going to be talking about the feasibility of an adapted quintet recruitment intervention to optimize informed consent in clinical trials in India. So that's a bit of a mouthful, but I will break that down as we go along. I'm here presenting on behalf of the larger study team named over here. The India CI, the India lead is Professor Nitya Gokte, who's the head of the Department of Clinical Pharmacology at King Edward Memorial Hospital. So in terms of the background, in India over the past decade, there's been an increasing focus on strengthening the clinical trials ecosystem through regulatory reforms, sometimes in response to ethical issues that have come up. But there have been waves of regulatory reforms in the country. There's a focus on streamlining research processes, approval processes. There is also an increasing emphasis on the ethical and methodological rigor of clinical trials. some of you may be aware, there is a huge body of bioethics literature on the ethics of conducting clinical trials in the global south. We were interested in finding out the empirical research base that pertains to the ethics of clinical research in India. We conducted a systematic scoping review narrative synthesis in 2019. We also conducted a stakeholder consultation process looking at the findings and identifying gaps. This was published in 2021 in the BMJ Global Health, and it really informed the work that we were doing in Orion I as well. I won't get into the findings in detail, but we looked at 80 articles, and what was clear was that a wide range of topics were covered, but studies often had very little funding or no funding, and they tended to focus on knowledge assessments, particularly with lay and professional participants, on topics such as, say, research ethics, and the studies were often conducted with easily accessible groups, namely ethics committee members and healthcare students, and less so with clinical trial participants. We've identified a range of research gaps, like I said. Happy for you to look at the article. But one of the key areas that we identified as a gap was the need to better understand the recruitment and informed consent process in India. And sort of on the back of that, we also, the lack of funding for these studies, we published an article on trials methodology research and what it is and the importance of it for India in the Lancet Regional Health Southeast Asia, where we emphasize the need for national and international funding, as well as highlighting some of the gaps, particularly around recruitment and informed consent. So that is, I suppose, the background in terms of the Indian context. I've mentioned the Quintet Recruitment Intervention, or the QRI. So this is an intervention that aims to understand and optimize recruitment and informed consent in clinical trials, primarily developed in the UK, but we've also applied this in the US, in other countries in Europe, in Australia, and now in India as well. There are quite a significant body of literature around the work, which you're welcome to look at. These are a couple of the protocol papers. So the work began in 1999 with a prostate cancer trial called Protect. And since then, because it worked successfully in that particular trial, we've integrated the intervention in about 70 plus RCTs. We've also conducted a before and after evaluation of the intervention, which shows that it works well in terms of improving recruitment and informed consent. These are some of the trials that we've worked on. So in terms of looking at the methods that we employ in the QRI, it's a two-phased intervention. So in phase 1, in order to understand the recruitment and informed consent challenges, we employ a range of methods, and then we bring that all together, and in phase 2, we develop solutions and implement them. Some of the methods we employ to understand recruitment and informed consent issues are, we look at the recruitment pathways, we look at the screening and eligibility procedures, we conduct interviews with trial staff and patients. We also audio record the recruitment consultation where the trial is put forward to the patient. We look at the documents, we observe the meetings, we bring all of this together, analyze it, present it to the chief investigator and the trial management group, and collaboratively develop a plan of action, and that is then implemented in phase 2. So this is very much a bottom-up process of developing solutions, and the way we implement it is through individual group feedback training sessions. We develop written guidance and various other things that we do to implement the findings or overcome the barriers identified. So I suppose with that in mind, a lot of us who work across the global north and global south would be really wary of transferring any intervention developed in the global north directly to the global south without adapting it. The MRC, the Medical Research Council, has put out the ADAPT guidance, which says implementing an intervention that already has a strong evidence base in one given context, adapting that to a different context might be more efficient than developing a completely new intervention for each context. And I suppose that's the premise on which our work is based as well. Obviously, this has to be context dependent and also requires careful and systematic adaptation. So that is the background. The aim of the Orion I study was to investigate the feasibility of audio recording trial consultations. And then once they recorded, the acceptability of using them to provide feedback to healthcare professionals in India, those who talk about the trial to patients, and to also facilitate scale-up in a larger study. Like I said, we carried this out at King Edward Memorial Hospital in Mumbai, the Department of Clinical Pharmacology. In terms of the methods that we employed, initially we obtained all the regulatory approvals, the Health Ministry Screening Committee, HMSC approval in India, Ethics Committee approvals. Then we obtained the informed consent from healthcare professionals and patients. We audio recorded informed consent discussions across 15 consultations in 2 clinical studies. We conducted interviews with healthcare professionals and with patients, 5 each, where we explored the perceptions of audio recording process, the feasibility and acceptability of that. And then once that was, did healthcare professionals, would they find the feedback acceptable? What were patients' views on that? What were the suggestions for QRA adaptation in India? We analyzed all of this. First, we transcribed it, translated it into English from Hindi and Marathi, carried out thematic analysis using techniques of constant comparison. And we were also able to triangulate across data sets, which has really been beneficial. And because of all the work that we did, we were also able to develop data management and data sharing mechanisms and guidelines that will help us in any future studies. So in terms of the findings, there was a high rate of acceptance of audio recordings of consent discussions. 17 patients were approached, 15 of them agreed. Recordings were integrated within usual clinical and research practice, and I think this stems from KEM being a very research active institute with a lot of prior experience of audio-visual recordings of consent discussions, which is a regulatory requirement in some trials. And generally, what we found was that patients and healthcare professionals, the ones that we interviewed, viewed audio recordings as acceptable for research purposes. So this is one of those really small but effective quotes. It's very simple and conveys the message. This is a healthcare professional who said, this we can do. Another HCP who said, these audio recordings can be analyzed, and the further process of having the informed consent during the trial can be much more beneficial. If there are any faults, that can be improved further. A patient who said the environment was pretty comfortable, it was for research purposes. That is one thing she mentioned clearly. They're talking about the healthcare professional. I feel recording part is right. Some of the reasons why they felt the way they did about audio recording consultations in terms of the advantages was interesting because it was for research purposes. They also saw advantages in terms of documentation and evidence purposes. And I think this again draws from their prior experience of audio visually recording some of the trial consultations. So this was a HCP who said audio recording can be properly accessed by the DCGI, which is a regulatory body, or ethics person. They can come and audit it properly. They can verify it in much better way than in written or verbal consent. A patient who almost reflected that view and said the recording, it didn't really affect the conversation, but it may affect further work. I think that is the point. Usually we need evidence for everything. Suppose it wasn't recorded and the person might claim, they forced me to agree. We will have an evidence that, no, it wasn't forced. That almost sounds like a healthcare professional's perspective, isn't it? But it is a patient. And also a healthcare professional saying, since there's no visual, the patient is less conscious as compared to audiovisual. But the advantage of audiovisual is we can have the facial expression as well. So a little bit of contrasting with just audio versus audiovisual. We also felt it demonstrates the voluntariness of participation, saying we can doubt the voluntariness of participant in written consent, but in audio recording, the patient is already there with us, so voluntariness cannot be doubted. A few other views from patients saying it helps to analyze information for the future. It is where you come to know the truth. And if the recording is happening, it's fine. Or if it's not happening, also I'm fine. So this is a patient who didn't particularly have views for or against it. It was just something they felt is fine if it had to happen. In terms of concerns or disadvantages, patients and healthcare professionals, the concerns they had were centered around confidentiality and the recording of personal data, health data. And again, this stemmed from their previous experience of audiovisual recordings outside of the Orion study. So this is a healthcare professional who said they would sometimes get anxious and scared as in patients, that we are agreeing to participate, we are assuring that we will follow your instructions, but still, why do you want to audio video record? Are you going to show it to someone? healthcare professional who emphasized confidentiality and said the storage of audio recording should be done in a coded manner. Confidentiality needs to be maintained. A patient who then sort of questioned what this meant for their future consultations. So they said, for research purpose, I think recording it is fine, but in normal conversation, I think it shouldn't really always be the case that it should be recorded. I should also be able to consult a doctor without being recorded. People find there are some diseases which a person may find awkward talking to a doctor, finding it being recorded is a little bit concerning. And in terms of providing feedback, so using these recordings to then give feedback to healthcare professionals, their perspectives were they anticipated being anxious about receiving feedback, but also were keen to improve how they communicated with patients through feedback. One of them said, I think that yes, it'll be better for me because I'm getting trained. Some discomfort for me, my seniors or my auditor might hear, and whether it is correctly I'm giving the information or not. And the interviewer says, so that doesn't make you worried? And the healthcare professional says, no, I'm concerned about it, but I'm not worried. It can be a training procedure. I will become more confident in the future. Another person who said, not worried, no, but anxious. Yeah, a little bit. Not a challenge, but at the back of my mind, it will be there that I will receive the feedback. In terms of the patient perspective, this is a very introspective patient who said they can improve on them, the healthcare professionals they meet. That is the point, and they can make themselves more clear about what exactly they want to say. Suppose a patient was just quiet and sitting over there, they wouldn't really get what was he understanding or not, but after the feedback, they would actually understand. Okay, he wasn't understanding, so I should have been more casual or more comfortable trying to see if he actually understood or not. That's really interesting that they said that, because that's exactly what the audio recording allows us to do, to reflect on the process in retrospect. They also spoke about some of the disadvantages or concerns, possibly saying the doctor may have made it clear from his point of view and the patient may not have understood it. So at times the doctor may have thought maybe it's not exactly my wrong position, that he may not have understood it. Sometimes the changes might be concerned to only one patient. So if he changes because of that one person, then maybe it can cause problems for other patients who feel comfortable with this normal style of speaking. So sort of emphasizing the need for a nuanced approach to feedback and not a one-size-fits-all. There were also suggestions for feedback mentioned by patients and healthcare professionals, the use of peer feedback, self-appraisal by healthcare professionals themselves, feedback being given soon after the appointments for real-time improvements, the use of a structured format for feedback were feasible, and also the importance of starting from what the healthcare professionals have done well. Bringing all that together, audio recordings of consent discussions were operationalized in the study without major challenges. They indicate that they are feasible and acceptable, and there are a number of adaptations to consider, reassurances to provide for healthcare professionals and patients based on these findings, and we're hoping to take this forward into a larger scale adaptation in India. This was a large team, not just the authors I mentioned, but at the funding stage, a large number of people were involved in terms of collaborators and advisory panel members who are mentioned here. References, and yes, thank you very much.
Thank you, Dr. Sangeeta, for such an enlightening presentation. But due to shortage of time, we will just move on to the next presentation.
We would like to invite Dr. Patricia M. Cook, MD-MS from Cardinal Santos Medical Center Research for the 5th presentation, Recruitment in Community Intervention Studies. Dr. Patricia is a distinguished medical director at the Premier Eye Referral Center and a dedicated member of the Cardinal Santos Medical Center Research Ethics Review Committee and the University of Philippines Manila Research Ethics Board. With a decades of medical career, she served as clinical associate professor at the University of the Philippines Manila and was editor-in-chief of the Philippine Journal of Ophthalmology from 2004 to 2015. So, Dr. Patricia.
Good afternoon. I hope you're still with me. We're still on recruitment, primarily in interventional studies. Now I'm going to present it from the point of view of an IRB. I'm trying to get used to this. Yeah, how do I move it forward? Okay. Okay, yeah. My talk for today will center on the different recruitment studies, particularly for intervention studies. I seem to have a, can I just do it there? So in the interest of time. Yeah, can I just do it on the, can I just do it, testing the, which one? The keys here. Oh, okay. I think we're running out of battery, I guess. Down, okay. Okay, in large-scale community studies, you know, testing the efficacy and safety of new drugs really require large-scale participation in order to meet the recruitment and the target date of completion. This is true, very true for vaccine trials where we really need thousands and you are dealing with vulnerable population. Through collecting accurate data and keeping precise records and measuring the results. These are really complex tasks involved with medical research. If you do a clinical literature review, you will find out that recruitment and enrollment are often cited as most investigators as the most challenging part of the process. Not only is having a large enough sample size essential for research integrity, but recruitment delays can also be extremely costly. I don't know why, okay. So what do we mean by recruitment? You know, when we deal with recruitment as IRB members, we are referring to, let me just go back to the previous slide. Sorry about that, I don't seem to be that techy. Okay. I just want to go. Recruitment aims to enlist appropriate participants representing the target population. You need to enroll the required number to fulfill the sample size requirement and the power of the study within an expected duration of time. So this will mean it's not only recruitment, you need to keep the participant in the study of a sufficient number, okay? Because if you don't do that, there will be serious methodological concerns that may influence the validity of the research findings. So what are the different recruitment methods? Most of these large studies are being done at the hospital or large institutions for safety reasons. So, of course, you would do recruitment within your own institution with education and awareness campaigns, trial promotion, and then if it's not enough, you will do community outreach and engagement support. As IRB member, we should look into that. We should also look into the materials they're only going to use, the advertisement, whether they use radio, TV, print, poster, flyers, brochures, digital advertisement through social media, blog posts. And in other institutions, they can hire third-party vendors and outsource to them those who are specializing in marketing and advertisement. So what are the barriers to site recruitment? We should know this so that you'll know what to look for when you are reviewing clinical trials, especially those involving large. But to find eligible participants, you really need to look at the inclusion and exclusion criteria. That's why all of these protocols do have several pages, especially the exclusion criteria. Then there are follow-up visits, the scheduled visit of the participants. Can the participant do it, the distance to the trial site, how often and the time? Are there sufficient resources for this recruitment? Reimbursement for the recruitment actually is going to involve resources. And there's a problem here. Anyway, I'll just go there. So what are the enablers to recruitment? If you train your staff site and you have enough resources, you're going to get good recruitment results. Adequate site budget, as IRB member, you should look into that. And the investigator, you know, you just don't delegate to your research coordinator, should at least spend some time in looking over. It's like the captain of the ship. You are responsible for all problems, even though it's done by your juniors. Good referral networks, access to a quality database, or if you're using electronic medical records, clear recruitment strategies and assign responsibilities for the recruitment plan for the research team. Efficient turnaround time for ethical review. Of course, we need to look at the informed consent form, adequate reimbursement for participants, especially for if they live far away, the travel, better site training of protocol requirements, and if you are using third-party recruitment aids, all of this should be submitted to IRB for review, and better site training to explain informed consent. What are the recruitment studies that have been reported in the literature, and of course you're aware? The one that is most talked about is the participant-centric approach. Why do participants want to join the study or are hesitant to participate in clinical trials? This we have to know. In general, there are heightened concerns around the safety, the use of placebo, burden of the trial, such as time commitment from the participant, travel time to study sites, multiple follow-ups. So they should be given, were they given enough information, like study materials, especially if you're going to do recruitment? You probably need to have some brochures, and this should be submitted to the IRB. Overall trial safety, schedule of visit, what tests to be done, travel reimbursement. And if you are going to have a partnership with a recruitment agency, as in some countries they do that, they should have a strong nonprofit partnership, like they have a patient advocacy group, etc. So, in general, you know, we're going to talk first, you're going to do it within the hospital. As IRB member, you should know whether the site can recruit that amount of patients. Do they see that many patients? Most principal investigators said they will. Then they found out that they couldn't. Then they have to go to the community. Maybe in Mumbai, wherein you see 44,000 patients, you can do it because all of the participants treat that as the center for where they get their health care. But not so in the Philippines. Unfortunately, we don't have that big a population. We have competing sites, okay? So then there may be patients, we need a patient who knows someone. So those are part of recruitment. And part of recruitment, I'm not sure what's happening here. I was talking about, okay? Then support from site recruiters, monitoring system. If you are going to use community recruiters, they actually should be part of the study team. Isn't that what you're saying after the experience at the PGH? They should actually be part of the study team and know and GCP trained, and probably as IRB members for such large trials involving vulnerable populations, especially vaccine, wherein you need to recruit 200 plus patients in a month. You need to look at all of these details. Is there any support for site recruiters, monitoring system? As you are saying, maybe the community recruiters you are going to should be only particular for that study and not be involved in too many studies. But then that will imply that she was just doing it for monitoring reasons and not for patient safety or community. Incentives, study design, resources, human factors, the communication, face-to-face initiation visits. So consequences of suboptimal, or if you have a failed recruitment, you did not do it, it's going to have an extended duration of trial. It's going to be more costly. Reduced statistical power of the study. You can get inconclusive study results, and then you may be forced to change your inclusion and exclusion that may influence the final outcome. You know, in some study, when they're already getting very nervous, then they started to change their inclusion criteria, exclusion. The overall outcome of the study, it can affect, or it could lead to termination of trial, loss of funding, and if, let's say your time is almost up and then there is a surge towards the end of recruitment, it can create an even workload and other administrative problems leading to prolonged recruitment phase that can affect participant retention. Then they're tired, even the participant, you know, you can lost to follow up, and even can affect the staff morale of the research team. So this could lead to recruitment misconduct. We as RRB members, we got to be realistic. You know, they're so competing. There are recruitment misconduct that not only unethical, could be fraudulent. And this can impact the participant safety, study integrity, and scientific validity. So anything in wrongdoing in research, we look into, is this intentional? You know, you knowingly do it, so you lead to reckless, fraudulent behavior like fabrication, pretend to be, you know, the participant can, you know, the exclusion card, you say, oh, I do not have that condition, will deny it, just so that they can get into the trial and get the compensation, okay? And therefore, this deviates from international guidelines. Common types of recruitment misconduct, misrepresentation of eligibility criteria. They are falsely deemed as eligible. We as IRB members, we should be aware of that. Are there any coercion, undue influence? They are pressured to join because they're going to be paid, or especially for those infant trial, the mother is pressured, oh, you're going to get some money, etc. You know, all of those things. Inadequate informed consent, failure to fully inform participants, adult participants or young participants with legal representative of the risks and benefits, over-recruitment or ghost participants, enrolling participants who do not exist, providing misleading recruitment data or manipulation of the recruitment data. We should all be aware of this. There are imposter participants giving false identification paper. They can give this to the study coordinator. But remember, the PI is responsible for all of this. So he should actually be involved. There should be supervision. Participants can be enrolled in multiple studies with the objective of generating income. This we call professional subjects. They can conceal their health information, or they can exaggerate their symptoms that they don't have so that they can be included in the trial. This has all been reported. So what's the consequences of recruitment misconduct to the participants? Risk to safety, long-term health impacts, and there is breach of trust. To research integrity, you can have data distortion, skewed results, delays in approval, retraction of studies. You probably read this in the literature. Research sources, you are companies involved in this will have additional costs. They could be spending so much, then they find out that the results are not approved or not to be included in the analysis. And most important is public trust. It's damage to the credibility of clinical research and those involved, such as pharmaceutical companies. So strategies to avoid or minimize recruitment misconduct. First, as IRB, when they submit, you should look at the feasibility assessment. Determine if the site has the appropriate expertise, right facilities, and resources for the trial. Find out what other sites are potentially involved in the same trial and whether there is a geographical overlap that could impact recruitment. Maintain open lines of communication among clinicians in the area to discuss the trial, identify overlapping population of potential participants or demand in resources, etc. Next. Prior to giving the approval, the PI need to have this startup from the study site resources. They have to undergo front trial planning and startup activities before the recruitment. And sometimes this will already involve 50%. As in anything, planning is so important for it to go smoothly. Okay? Identify key staff, clarify roles and responsibilities. So as IRB member, we need to see this delegation of responsibility, including the names and what they are for. Okay? Develop a realistic and methodology participant recruitment plan before you approve any clinical trial, especially that will involve community. In the recruitment process, we pay very particular attention as IRB member. What are the methods they are going to use for participant requirement? If they said they are going to recruit only in the hospital, look at the size of the hospital, how many patients they see. If they are like the hospital in Mumbai, 44,000, maybe no community recruitment needed. But in the Philippines, we don't have such a very big, even in Philippine General Hospital. So you're going to use a diverse set of methods and strategies for minimizing the chance of sampling or enrolling professional research subjects or deception and fabrication to quality for inclusion to the trial. And if there are changes of recruitment not mentioned in the protocol, amendment should be made by the PI. I know some forgot about it because right from the start, they will let you so that they will get the IRB approval earlier. They will say, oh, only hospital. Because if they mention community, then they really need to identify which community, how are they going to. And unfortunately, some people are in a hurry to have the trial approved. So if they're going to do recruitment, community-based recruitment to supplement what recruitment they can do in the hospital in order to fill the demands of these large studies, this will depend on the prevalence of the disease condition and the complexity of eligible requirement. And you will have to engage with people. Let's say the local community, you may have to ask, And because if you're going to use community, you have to also see to it that the community will benefit from this clinical trial, okay? So it's not just you go to a community, you start, your recruiter come in, and then they're going to start recruitment. You have to, if you're going to involve community, you have to make sure they are also part, they will benefit from this trial. So in other words, you should know what are the disease prevalence in that community, how can you help prevent that disease, and what do they need in order for your recruitment to be successful. So there should be social preparation and assessing the socio-economic and cultural profile of the said community, including their health-seeking behavior and health service system. These are factors we have to consider when you are planning your strategies and activities for community-based requirement. So the key point here, okay, you engage the community members in research regarding the benefits of study recruitment participant, and you engage also somebody who knows the area well and who may be your community recruiter, but you need to bring him or her as part of the research team and train her with him or her with GCP training, ethical issues, how to get the right informed consent. So the key points here in my next two slides. If you are adopting a community-based recruitment strategy, it must already be decided at the planning stage for efficient coordination of activities. It should be conducted under specific inclusion and exclusion or withdrawal criteria aimed at promoting and safeguarding the right, safety, and well-being of trial participants. And in the participant selection and recruitment, there are various ethical considerations. Conflict of interest of sponsors, investigators, and the recruitment team, protection of privacy and confidentiality of participant information, informed consent and recruitment modalities, vulnerability of the participant, incentives and compensation for subjects, community considerations, and in ethical recruitment to prevent misconduct and ensure participant safety. And you have to be aware recruitment, misconduct, and wrongdoing threaten both participant safety and integrity of the research findings. So efforts to identify and exclude ineligible participants are really very important. And you have to use a multifaceted approach using various methods and strategies to prevent and detect recruitment misconduct in clinical trials. These are my references if you are interested. Thank you for your attention.
At the end of the session, we had a very important topic from Dr. Patricia, and she discussed about the barriers and enablers, as well as the various recruitment strategies and the consequences of failed recruitments. And to me, it looked like you can keep the presentation as your checklist or SOPs while you are undertaking the clinical trials. We have guidelines and all those things, but still it is so clear and concise that we can use it a very useful thing. Thank you so much, Dr. Patricia. And we have, and at the end of the session, the 5 presentations are over. And one very pertinent question, only one question, please. For Dr. Patricia, one question.
Thank you. Sorry to keep everyone. Thank you, Doctor, for your insightful presentation. I was wondering, you focused a lot on the patient or participant-centered kind of recruitment strategies. We have a lot of trouble engaging clinicians in recruitment and a lot of clinicians who oppose enrolling their patients into clinical trials. So you only end up having some keen clinicians who do trials and then most people don't. What do you think we should do in terms of recruitment of more clinicians and researchers?
You know, most clinicians are afraid that you're going to steal their patient and their patient will not come back to you. That's the problem. I'm a clinician myself. So I think it's also education within, if you are in a hospital or institution, especially academic. We need also information about, for those not involved in research, that there should be no fear about, I'm going to steal your patient, and my patient love me, and then they will already come to my, you know. I guess if I am the principal investigator, you have to return the patient to your colleagues if you want to get their trust. Oh, it's very common.
With that word from Dr. Patricia, we would like to end the session and thank all the participants. And last few words from Professor Dr. Ajit Rai-Majhi before closing this fruitful session.
I would like to thank all the speakers for such a motivational presentation. Also thank the audience for actively participating. I would also like to thank all the supporting staff, the IT, the hospitality, for helping organize this session so nicely. Thank you.
Thank you to our esteemed presenters and chairs for making this session more interactive, more informative and interesting. And we got a lot of interesting informations about ethical principles and issues while recruiting human participants in conducting research. So up next, I would like to kindly request our honorable chairs, Professor Dr. Atri Shah and Professor Dr. Ajit Rai-Majhi, to present token of appreciations to our esteemed presenters. I would like to invite them to the stage. Also, I would like to present Dr. Noor Hajwani, Mohammad Jamili. Dr. K.V. Ganapati. Wait.